Just a brief kind of overview or a look at yesterday. I think sometimes, as we all know, these projects we start on may make us think that they're insurmountable and that there ends up being it's just too big and we can't do anything. That, I will tell you, is not an option. Even if we do small things, they're still relevant. So let's not let this get, where, we just throw up our hands and say, what the hell? I mean, which is easy to do because from yesterday, what we heard yesterday, it would be very easy to just punt this down the road. We can't do that. And I believe all of you understand that we cannot do that. We have to come up with, even if they're small things, we have to come up with some solutions to this problem. Going on like this and spending $46 million a year in contract nursing at Larned Hospital is, quite frankly, a disservice to our people, and it's just not an option. So no matter how small we do things, all your ideas and stuff like that, we still need to focus on that problem. So with that, I'm Representative Buehler.
Yeah, thank you, Mr. Chair. I appreciate your intro there. And on the drive in this morning, I was thinking along the same lines. I'm wondering whether we plant the seed with KLRD or somebody. An observation for me is it's real easy to get myopic when we are either looking at budget appropriations or whatever. But what I'd like to see, and it would require maybe either just an extrapolation of what's been in the past and project that forward, or maybe with a little contact with the state hospitals. But could we get a 3-year and then a 5-year projection, assuming nothing else changes? Here's what the cumulative contract nursing costs would be 3 years from now and then 5 years from now. Because it's one thing to say it's a $46 million problem this year, but when we looked at, I forget who presented it yesterday, the actual cost from whether it was the last 4 years, I mean, it went from 5 to whatever million. So that helps me, and I think it would help all of us frame solutions. So, I mean, it's not just a $46 million one-time problem, it is the cumulative impact of the next 3 to 5 years. So I don't know if we could get some help from KLRD to do that, or how to frame that up any better. I see smiling faces over there. But I mean, if we're building a business case to look at what our options are, I think we need to know what the cost of not doing anything is. So that's just a thought.
And I think that's a great idea.
Thank you, Mr. Chair.
Senator Gossage.
I also was thinking about that on the way in, and we're talking about this $46 million problem, but is it really? In that, if all of the contract nursing went away tomorrow, would we be saving $46 million? We would not, because we would need to hire state employees to do that. So I would like to see the difference. If we just had state employees to replace the contract staffing, what would that be? That is the target that we're looking at, that savings there.
That's true. Representative Ruiz.
Just to add to that, I think what we would need to also look is what would it look like raising the salaries of all the state nurses in order to keep them.
I think that's good. You guys getting that down? Okay, very good. Yeah, and while we're talking about that, it's probably could require an investment ahead of, to offset that of 20 million, but still, it would still, pay for itself if it was an investment of, we talked a little bit about, and somebody had the idea of, say, we have these small rural hospitals that may have a wing, and I'm just brainstorming here. I don't know what the cost of a remodel would be for them to house some of these folks, but I think that, if you made a $10 million investment even to bring them up to standards so they could house these folks, you would be operating in a different labor market, versus Larned, which we know is saturated, but if you took that in and say moved it to someplace else where there were employees in that area that could staff that. I mean, everything's on the table, but, we know a lot of these little hospitals have 20-bed wings and things like that, and may be able to staff a wing of 20 people, or, you know what I'm saying, and just take it off that way and not have to pay contract labor for that. Just brainstorming, and I'm more than willing to listen to it.
Maybe it would be helpful when Scott gives us the information on where these people are from and that competency.
Yeah, exactly. So it's just, everything's on the table still. But I just want to make it clear that there isn't the option of doing nothing. Representative Rivas.
Yeah, I think one other issue we really need to put out there is the pipeline of nurses coming in, because it sounds like we're not getting enough nurses to supply the need. I think nursing school has been behind since the 80s. It's never been caught up. We've always had a nursing shortage. So I don't know if there's maybe we should encourage like the nearby community colleges to get a program going for LPN, or that way you're kind of growing your own from home, that they're in the region, they're likely to stay in that area, and they can do clinicals at those facilities. So maybe there should be a component of recommendations for expanded nursing programs.
And I agree 100%. I think we heard some of the barriers yesterday to producing nurses in our state. Keep in mind that everybody's competing for these nurses too. So the hospitals are behind, and they're paying contract labor. So us siphoning off, if we had 100, we might get 3. You know what I'm saying? It's a nationwide, it's a statewide nursing shortage. So Senator Murphy.
Thank you, Mr. Chair. And also, as we heard yesterday, we've got a sort of a poor product coming forward. And so a lot of people aren't even able to if they want to. And so our problem is much deeper than just contract nursing.
Agree. I think our eyes were all opened yesterday with that slide from Dr. Flanders and that's, although it's not quite in our bailiwick, there are some folks at this, in this committee that it is, not mentioning any names or anything, but there are some folks that are involved in that other process that we need to take a look at too. And this committee, I think, would help that person and that committee any way we could. So, yeah, thank you for that. Representative Reese.
And we can't forget also that what we also heard is that there folks that are coming from other states are not prepared either. So it's not just Kansas, it's other states too. So I'm not, do we need to make changes to that? Yeah, absolutely. But also wouldn't want to see that prevent us from making advancements to like the scholarships. There's several scholarships that are available. If we need to build in, remedial math, a course that you have to take, then fine, then do it. Let's put it in there and acknowledge that they're not prepared, but don't turn away possibly really good students because they can't pass the math.
I agree. I think that's one thing in that scholarship program we should probably, whether we like it or not, we should think about paying for remedial classes. I mean, that's a sad thing to say, but if they're not coming out ready to go and they don't have the money to pay for the remedial classes, such as like the Promise Scholarship and stuff like that, we might think about that. I mean, again, too bad we have to think about that, but that's reality. So, okay, well, I've digressed enough, but I did wanted to say that. All right, we're going to have, Wendy, are you up?
Yes, sir, I'm here. Good morning.
And Ted, are you there?
Yes, sir, I am. Good morning.
Very good. welcome to committee, and thank you for your time commitment to help us understand a little bit more about what you folks do. So kick it off.
Great. Well, good morning. I am Wendy Morris. I'm a senior behavioral health advisor for the National Association of State Mental Health Program Directors, or NASHBID. And we are a member organization that serve the state mental health authorities in all 50 states and the territories. Before coming into this role, I served as the commissioner for the Department of Behavioral Health, Developmental, and Intellectual Disabilities in the state of Kentucky, where we do have privatized state hospitals. Prior to moving to the state position, I was the executive director of one of those hospitals and the chief nursing officer before then. So I've enjoyed the conversation this morning about your nursing crisis there. You all made a lot of really, really great points, and it sounds like you're asking all the right questions. So that's terrific. So if you go to the next slide. We, of course, are here to talk to you about privatizing state hospitals. And I'm going to talk to you a little bit about the experience here in Kentucky from my perspective. And again, I did work for this nonprofit healthcare system I'm going to talk about first for a number of years that was in a partnership with the state to run one of the state contracted hospitals. Here in Kentucky, we have 4 state hospitals and 1 forensic hospital. Those 4 acute care psychiatric centers serve distinct and defined regions of the state, but collectively all 120 counties are served, but they serve specific regions and specific counties. So the first time that the state of Kentucky entered into a partnership for the oversight and management of a state facility was back in the 1990s. When they partnered with a large nonprofit healthcare system in the eastern part of the state. This is a very mission-driven organization, and they actually put in statutes and regulations a very narrow definition of where a hospital was to be built in the eastern part of the state. It was so well defined that only 1 city fit the description that they put in statute. And then the state paid to have that hospital built. It was actually a distinct part unit of a regional medical center. So from the street, it looks like a freestanding hospital, but it's connected by a small hallway. So they share ancillary services and support services, but most importantly, it is not an IMD, an Institute of Mental Disease, which means it can bill Medicaid. So it was a huge win-win for both the state and for this mission-driven organization at the time. And it also, because of that, the statutes and regulations, there was no request for proposal required. So they were able to move forward rather quickly once those decisions were made. The hospital is operated under a contract with the Department of Behavioral Health, so with the state. Interestingly, the way it was set up is the ownership of that facility, that hospital, that building transferred to the healthcare system over a period of, I think it was 20 years, as you know, with the loan and all that was paid up and it was depreciated. So at this point, and for several years now, that healthcare system is the owner of that building. They still operate it under a contract, and I'll talk a little bit in a couple slides about some lessons learned and some recommendations, maybe what some pitfalls were with that approach. And I understand you're already building your hospital, so that's really not an option at this juncture for Kansas. The next time that we entered into a partnership was the hospital opened in 2013, but there was a shared vision between the university and the state prior to the build. So there were lots of meetings and convenings and talk about what this hospital was going to look like, the service it was going to provide. The university also has a hospital, a large, very large medical center where a lot of people from across the state go for care for any number of medical issues. They're a teaching hospital. They embrace research. And the vision was for this psychiatric hospital, this state hospital, to have be that kind of same stature as the university hospital. Again, there was no request for proposal required because it was a university, a state university. It continues. It's operated under a contract with the Department of Behavioral Health, but unlike the first go around, this time the state maintains ownership of the facility, all the equipment, the medical records, the electronic medical system, so on and so forth. A couple interesting points about this. NAMI, the National Association, the National Alliance for Mental Illness, the local chapter of that, had a big voice in the process. They were huge advocates for this hospital. It replaced a facility from the 1800s, so it was very, very needed. And they continue to have a presence in the facility. They have office space in what's called the Recovery Mall. They do hold some small groups. They offer some peer support services. And they also participate in the governing advisory committee to continue to have a voice. And we have found that to be very helpful to make sure that the people we serve have a voice in how we're running the hospital. I heard you all talking about clinical rotations and some of these things, and that's been a big thing with our partnership with the university, because they do have a psychiatry program. So we have residents that are there. We have social work students, psychology students, nursing students, the whole realm. They come for clinical rotations, and it is a good recruitment tool. And also, just while I'm on the topic of universities, it's my understanding that Kansas does have a behavioral health workforce education program through the University of Kansas, and that the Wichita State University is part of a collaborative effort. I don't know. I'm not sure if they're part of a newly formed Behavioral Health Education Center Alliance that's hosted by the Education Center in Nebraska. They've only had a couple meetings. I've been able to join both of them. But it's a way for states to come together and think about workforce development and what's working and what's not. And I didn't mention at the beginning, but workforce development is a huge piece of the work I do here at NASHBID. So I do have some knowledge about what's happening around the country. Next slide. Another way that we partner, and this is not for the whole facility, but to address the staffing issue, we do partner with local community mental health centers. Now, in Kentucky, there are 14 community mental health centers that collectively serve all 120 counties, just like the hospitals. And so each hospital works with 3, 4, 5 community mental health centers. They serve the same geographical area, so they work very close on kind of that front door right admissions and the back door or discharges back to the community. Again, there are statutes and regulations that define what the community mental health centers do, and it includes the entire continuum. So they do have some responsibility for the inpatient, even though they don't run any of our psychiatric hospitals at this time. But we do contract with them for some staffing, because there are some difficulties recruiting, at the staff level. Salary, which you all discuss, is a big thing, especially when you're talking about facility directors, leadership positions, but also with nursing. And so we have entered into, I think, for the two hospitals that are not privatized and our forensic hospital all have contracts with the local community mental health center to help with some of that staffing, so that we have local people to come in and do that. Again, because of the way community mental health centers are structured in Kentucky, there was no RFP required. So we already have existing contracts with all of them to offer certain services. So we simply added clauses for the provision of staffing and how that works. So they are employees of the community mental health center that work in our hospitals. And so we have to, human resources from the two entities have to collaborate on issues, but it does, it does make some things quite a bit easier. And then the other type of partnership is, I mentioned NAMI before. Most of our hospitals have some presence with NAMI, again, because they do interact with clients. It's not really a solution for staffing, but it does get a few more people in the facility who have a vested interest in what's happening and can provide meaningful services to patients. some of the benefits of that staffing contract with the CMHCs are, things like I said, salary, but also job descriptions. It's very difficult to change a job description or add a new job description, at least in Kentucky, and I assume in Kansas. It's also sometimes can be difficult to, if you need to terminate somebody because of bad outcomes, or to hire somebody quickly. So some of those issues were overcome by entering into that contract. Some things that I heard you all mention that I wished I had known about when I was running the facility all those years ago. You talked a little bit about pipeline, something that I don't think is happening anywhere yet, but there are states starting to talk about partnering with higher institutions of higher learning, specifically technical colleges, to provide mental health aid training to high school students. Our youngest daughter graduated from high school, a certified nurse aide, and went immediately into the workforce a week after she graduated from high school. There's no reason we can't do that for mental health aides, mental health technicians. So certainly something to think about. I also heard you mention scholarships. That is very much trending up. Instead of loan repayment, moving towards scholarships. Tennessee started a program just a couple of years ago. They are inundated with applications, have actually had to close down their portal. But that's in exchange for work time at the state. So they get a scholarship. They're doing it for social workers. Obviously, you could do it for nurses as well. And then they have to work for the Tennessee state system for, I think it's 2 or 3 years. Next slide. So some of the lessons we learned here in Kentucky about privatization is absolutely not a magic bullet. It's not going to solve all of the problems, but it will, it does address several problems. One is staffing definitely continues to be a challenge. But again, because there's flexibility with the hiring process, job descriptions, and offering certain incentives like sign-on bonuses or merit raises, some other things that maybe the state doesn't do, it's good for both recruitment and retention. It's interesting that the university that's running our hospital was able to attain magnet status nursing in that state hospital. I don't know of any other state psychiatric hospitals in the country that have achieved magnet status. I'm not saying they haven't, but I'm not aware of them. And this, if you're not aware, is the American Nurses Credentialing Center recognizes excellence in nursing practice, leadership, and innovation. So it's a very high achievement. And it's a thing that nurses look for when they're looking for where they'd like to work. The next thing I want to talk about a little bit is the budget. Budget containment can be very difficult when you enter into these types of contracts. This is the numbers are from the university contract. I don't have them all the way back to 13, but you can see the uptick in costs from fiscal year 21 to 25 was significant, a $22 million increase, a huge increase. Their census had gone up a little bit. And so, I wasn't there at the time because I had moved for this negotiation because I had already come to Nashville. But I will say it's very, very difficult for a state to walk away from these types of arrangements without a very solid transition plan, whereas it's much easier for the contractor to walk away. I mean, especially with the situation I talked about with our, with the group we contract with in the eastern part of our state. They even own the building, right? So what's their incentive to continue contracting with us? So it does make contract negotiations very tricky over time, especially if there's turnover in leadership at the state level or the contractor organizational level, because the original intent, the original vision can be lost over time. So you certainly want to make sure that would be included in any contract you enter into so that it doesn't get lost. And then I will say lastly that even when there's a contract, the media and litigators will still hold the state responsible, especially if the facility name clearly indicates that it's a hospital. Several states have an Eastern State Hospital. So when it's named State Hospital, obviously when it hits the media, everyone will see that as still the state's responsibility and not necessarily the contractors. Next slide. So some recommendations. The biggest one is to ensure that the contract protects the state's interest. I think the contract we have at the university is much stronger than the contract we have with the healthcare system. We want to maintain a level of oversight of operations and budget. We want to assure that that facility is going to admit court-ordered patients, patients who are difficult to serve, difficult to place. We want to make sure that the state mental health authority or your department or division of mental health has 24/7 access to that facility, that they can interact with the patients, and that they have access to patient records. You want to be sure there's very strong performance and quality indicators in place, require accreditation from Joint Commission or another recognized body. I believe maintaining ownership of the building, the equipment, the electronic health record is very important, because if anything that you cannot currently foresee happening does happen, right, that you have an out, and there you don't have to negotiate who owns what. And to have a think about the process for transition back to the state if that needed to happen. Also understand the interest of the contractor. I think that's very critical. That interest needs to be something other than financial. What's their vested interest in your state, in Kansas? For the two private contracts we entered into, the first, again, was a mission-driven healthcare system. And this arrangement helped them bring a very needed service to their community. People from Eastern Kentucky were having to drive to Central Kentucky or being brought in the back of a police car in handcuffs for 2 to 6 hours, depending on where they lived. Now they can get that care much closer to home. And one of you mentioned something about smaller hospitals. While the original building was 100 beds, during my tenure as commissioner, we moved some of those beds actually out to some of the smaller hospitals. Again, it's a healthcare system. They have a presence in Eastern Kentucky and in West Virginia. And so they had 2 other hospitals in that region they were serving that had existing psychiatric units. To your point, we kind of brought those up to speed, up to snuff, and were able to admit state patients to those facilities as well. So now the original 100 beds, I think, is 75, and then we've got 2 smaller units in the community for folks who have less acuity or need shorter lengths of stay. So that's the reason it mattered to them, because and why it helped Kentucky. And then our university partnership, again, this is a state university, and they saw this as an opportunity to develop a center of excellence, and they have. It's costly, but it's a good hospital, and they provide great care. All of our hospitals do good work, but like I said, they've achieved magnet status. They get great scores when they go through accreditation and so forth. And also the second thing here, the second point, is to create an organizational structure that makes the facility director accountable to your state mental health authority, again, your department or division of mental health. Transparency with the state is crucial through this contract. You're going to want immediate notification of any major event like a death or a major power outage, anything that might have potential for media, investigation, or litigation you're going to want to know about. Next is to require admission assessments and determinations be done in the community instead of at the hospital. This serves a couple purposes. One, it prevents the contractor from denying care to difficult to serve patients or patients who are difficult to place, to forensic patients or to court-ordered patients. And on the flip side, it prevents them from admitting patients who can be served in the community, right? So you don't take up beds with people who could get community services just to fill beds, especially if there's a financial incentive to fill beds. Next is to put an advisory board in place led by the state mental health authority, and be sure to include community stakeholders. That might be your outpatient providers. It might be, again, your advocacy organizations like NAMI or Mental Health America, whoever is kind of your big stakeholder players in the state of Kansas. And then last is to review performance and quarterly quality indicators on a routine basis. So, seclusion restraint, medication errors, the standard type of stuff, but also you're going to want to look at any incident reports, any injuries, any allegations of abuse, neglect, exploitation. You're going to want to process for mortality review. If there's a death, you're going to want your state involved in looking at those records and making some determinations. And you're also going to want to access all survey results, not just from accreditation, but any investigations, be they from the Office of Inspector General or for Protection and Advocacy, or anybody else who is in your hospital doing that. And that is what I have. I'm going to turn it over to Ted to talk from a more bird's eye view, and then we should have time to take some questions. Thank you.
Thank you. And, Wendy, many of the points are ones that I'm going to come back to, because we've been working with a number of states looking at their experience with privatization. And for a project for Alaska several years ago, got sort of their recommendations about what to consider if you're doing privatization, and they really reinforced some of Wendy's messages. But yeah, my name is Todd Lutterman. I'm with the NASHBIDS Research Institute. So we are a separate 501 nonprofit that were spun off from NASHBID 30 some years ago to really do data collection, policy analysis. We leave it to NASHBID to do advocacy with Congress and the federal government, but our job is to work with them to identify key issues, collect data, do policy analysis. So we've been tracking for many years what's going on with states, state hospitals, and what we saw this year was more states than ever before reporting an experience of shortage of psychiatric beds. 43 out of the 48 states that responded. And what we could see is forensic beds, these are people sent by the courts for competency evaluation or restoration, not guilty by reason of insanity, in some states, a sex offender statute. But that's a major shortage, and those are almost always done in the state hospital. But 39 states reported a shortage of acute beds. The state hospital for 26 states for adults. Only 15 states reported shortages for kids for that, but in over 30 states, they don't treat any children in their state hospitals anymore. They've really tried to reserve the state hospital for adults and forensic patients. And so the shortages for kids are really being seen more in other psychiatric inpatient settings and in residential treatment programs for children. There are also shortages of long-term beds that we see across the states, both in the state hospital and in many states they're relying on these other psychiatric settings. So general hospital psych units, private psych hospitals. One of the issues that we've heard in some states is the state was transitioning using their state hospital more for forensic clients and we're relying on the local general hospital psych units and private psych hospitals for civil status patients, people not involved with criminal justice. And then some of those private hospitals found they could make more money by shifting away from psychiatric care. And so they shut down, and then all of a sudden the state's left with a shortage of beds because they were relying on a private provider that decided they could make more money doing sports medicine, fancy maternity, just whatever, or they couldn't staff the program for psychiatric. Anyway, these shortages are often just because it becomes outside their control. If you go to the next slide, this just sort of shows, and we're somewhat trying to still understand why, but every year that we've asked states, we've had an increasing number of states with shortages of beds. In particular, it's been this growth on the forensic side where states are seeing shortages of beds, but it's across the board, most of the states are seeing the shortage. So part of this was just to make the point, Kansas is not alone in this. This is something that's going on across the country. With states experiencing shortages and trying to ramp up capacity. So if you go to the next slide, this was for the first time in the years we've been studying this, that we actually had states not closing hospital beds or downsizing their system, which has been what states had been doing since the 1950s, when we had over 500,000 people in state hospitals. And then there was President Kennedy's Community Mental Health Center Act and the whole focus for building community systems. But what we see today, the blue bars, there are 10 states increasing capacity of one or more hospitals. We've got 3 states, including Kansas, building a brand new hospital. A number of states replacing an old hospital with a new hospital. But the number of states that were closing or downsizing hospitals has gone to 0. And we've got the states expanding capacity. What's interesting in the middle, though, back in 2000, there were 10 states that said they were either considering or had just privatized one or more of their state hospitals. Today, that was 0. Kansas hadn't responded that you were considering it when we did this survey back in the winter. So there has been a lot of work on privatization over time. There are 2 states that had privatized whole hospitals back then, Florida and Kentucky. What we do see, though, more of is there are states that have privatized parts of the hospital, privatized, maintenance, food, laundry, various aspects of it, but turning over the management of the entire hospital to a private contractor or a university like Kentucky did is a little bit different. And I'll talk a bit about what we're seeing from states or what states had done. The other, I think, important thing, if you go to the next slide, is we just did a report that we presented at the NASHBID's annual meeting for commissioners last month in July. And we were looking at who are the patients in state hospitals. And what we've seen is a big shift that has some implications for your thinking about staffing. The blue line at the top are the civil status patients, people that are voluntary or involuntarily in the hospital because they're dangerous to self or others, but there's no criminal justice involvement. And that's been going down throughout time. That's been growing are those people sent for competency restoration, people found incompetent to stand trial by a judge, and they're sent, or by an assessment, and the judge sends them to a hospital for treatment in order to become competent to stand trial. And that's been growing across the country, both in the terms of admissions. And the next slide looks at the number of residents in the hospital on a single day. If you go to the next slide, it's a similar message that what we're seeing is a shift in who's in the hospital, and they're more forensic clients than they are the civil status patients. Particularly the competency to stand trial. So these are people that are sent because they've been found to have a mental health issue where they can't understand the charges against them. What I understand from talking to this hospital staff and the forensic experts is that, you know, this group may have more tendency to some violence, some interactions, so that the staffing level needs to be somewhat more higher. The nurses and the people treating them need more training in de-escalation techniques, not just the mental health treatment, but how do you work with somebody who's had this criminal justice involvement? They're coming out of a jail setting, probably transferred to the hospital. And so it may require a higher level of staffing to address that population as they're coming into the system. The next slide. We did ask states in 23, 2 years ago, about workforce shortages and by what types of staffing. And you know, the red, if you go to the next slide, sorry. The red were states said they had catastrophic shortages to the level where they had to close some beds. And what you see there is the registered nurses, it's the third from the bottom. There were shortages in almost all the states with nurses, but 7 of the states had catastrophic shortages of nursing where they were having to keep beds or units closed because they didn't have enough nurses. The other area, 24 states reported at least a moderate shortage level. No states reported just a minor shortage of nurses. So if Kansas is experiencing a shortage of nurses, you basically mirror the rest of the country. You know, other areas, you know, the social workers, psychiatrists, getting them to work in your system, psychologists, other nurses. So there's a shortage of workforce across the country for state hospital staff, but nurses and psychiatrists in particular. If you go to the next slide, we did ask states, what salaries are they using? What is their average, you know, entry salary? What's the median entry salary? What's the top salary that they'll pay for different types of staff? There were 40 states or so that responded. Kansas did not report, so I don't know how Kansas's nurses' salaries fit in here. But you see the average salary for a nurse, and this was in 2023, was starting at $65,000. The median state was $66,000. The top salary, you know, $98,000 to $101,000. You know, for the average for the highest salary, and then the actual maximum in one state was actually $139,000, and that was with 29 states reported on nursing shortages. We do have data that we can share with the department for the states around Kansas if they wanted to compare and just sort of see how competitive you are with other states. But you know what, you know, is I think you guys were talking about earlier on at the start of the meeting is there's just a shortage of nurses across the country, and you know, how much do you have to increase salaries to get nurses to move from Nebraska to Kansas, and then Nebraska would probably raise salaries back. So figuring out how to grow the workforce, I think, is more some of the ideas. If you go to the next slide, one of the things we did ask states are what are their initiatives to support recruitment and retention of workforce? And so, tuition reimbursement was one of the things, recruitment, increasing salaries by 23 states, providing on-the-job training. One of the things that a number of states found just was offering more flexible scheduling. One of the things that Michigan found when they were discussing privatization was that the state employment rules about how they could move nursing and other hospital staff around were a barrier. And when they had more flexibility, basically they had strong employee unions in Michigan. They came to the table and made some flexibility more in terms of scheduling for workforce, and they found that that really helped with the retention of the workforce. So I'm not sure where that is in Kansas. The other is building career pathways. As Wendy Morris said, we've had several states that are working on programs where they take LPNs who are working in their facility and help them get their RN degree. And so how do we help people that are at least interested in behavioral health move up and become, a registered nurse or something that you need more? So the next thing I want to turn to is what we did hear about privatization. If you go to the next slide. In 2020, so this is now 5 years ago, we partnered with the Western Interstate Compact on Higher Ed, WICHE, to do a report for Alaska, which at the time was concerned about their state hospital that had lost accreditation and certification. And they'd had to sort of stop admissions for a while. And Kevin Huckshorn, who will be talking next, Dr. Huckshorn, was helping work with Alaska on that also. But they asked us to do a study about what were state experiences of other states with privatization. And so we interviewed a number of states about their privatization experiences. 2 states that had privatized entire facilities. Florida has had over 20 years of privatization of state hospitals with some for-profit companies running them. And then, as Wendy said, Kentucky, which has the state university and a regional, health system. We talked to people in Georgia that's privatized some functions of their hospital, food service, maintenance, et cetera, but they had done an RFP process and then decided not to privatize the entire operation of a hospital. And then we talked to teams in a number of states, Indiana, Michigan, Colorado, Missouri, West Virginia, that had all explored privatization, but none of them had actually moved forward with privatizing the entire parts of a hospital. What Colorado ended up doing was contracting with a private provider to do some of the competency work for people that were going into the state hospital to free up beds. Missouri, interestingly, closed the acute units of their state hospital, so they don't do acute care in their state hospital. They work with their university medical centers to set up inpatient units that would be part of the university hospital to do acute admissions. As part of a general hospital, they could then bill Medicaid. Again, they're not then restricted by the Medicaid Institution for Mental Disease restriction. And then Missouri state hospitals are used for people who need continuing long-term care or almost entirely for forensic people that wouldn't go to the university hospital. If you go to the next slide, though, we got some great lessons learned, recommendations from these states that had looked at privatization or have experienced privatization. And number one that came up state after state, and it was part of Wendy's points also, if Kansas wants to look at privatization, you need to have really strong contracts and safeguards, clear deliverables, outcomes, and performance metrics. Require vendor accreditation, the Joint Commission or CARF, with penalties if they lose accreditation. Strong termination and transition clauses. One of the states had had experience with a private vendor who, when they went to shift vendors, they were claiming the medical records and all of that belonged to the vendor, not the state. And so it's very clear, they kept saying, make sure that the state maintains ownership of the electronic health record, of client records, facility equipment. If the facility owns, the contractor owns the building, then if you change contractors, you have to then pay for a new building or how that gets spun up. Incentivize efficiency and performance while protecting state interests. The second emphasis was oversight and accountability, so that the state should retain authority over admissions, discharges, and transfers. Again, as Wendy said, to assure that you're preventing cherry picking, that they're not avoiding accepting people who may be difficult to treat, who really need to be in an inpatient care. Require adherence to state reporting rules for adverse sentinel events, seclusion and restraint, medication errors, etc. One of the things that Florida said was they're very happy with their privatized system, but the state couldn't just rely on the private contractor. They have a dedicated state employee who works to supervise the contracts, so the full-time FTE, and then clinical staff, including nurses, who focus on reviewing records and monitoring what's going on at the privatized hospital. The next slide has some final recommendations. Again, they thought that stakeholders and community engagement was important to developing the RFP and going throughout the contract evaluations. Ensure transparent communications among the different state agencies. What's Medicaid's role going to be? Are they going to help pay for this? The vendors. States have found that the courts, sheriffs, and community partners, community providers were important to have involved in this. Advisory boards, dedicated space for NAMI, which is something that Kentucky's done, but other states were looking at that. And the thought of working with your state universities for workforce development support was really important. The fourth one, continuity for care and transition. So plan for a seamless transition if the vendors leave. How do you avoid disruption in care if you need to change providers? Protect and retain the client's medical records across the different contracts. And think about, how do you make sure you've got a way to transition people from the hospital to the community? Make sure you don't have a system that has incentivized to keeping the beds full. So when somebody may be ready for discharge, the hospital has an incentive to keep them. And final, write the RFP based on future systems need rather than just current operations. So if you know that your system's going to be changing, I think everybody's right now, and we talk with, is a little uncertain what's going to happen with the one big beautiful bills, changes in Medicaid and the ACA enrollment. So people's insurance and coverage may be changing. So some flexibility on that. Explore outsourcing the ancillary services for efficiency. And then particularly consider alternatives like jail-based competency to relieve the hospital demand. We've got a number of states that are working. California is spending $500 million with their counties to set up community-based competency evaluation and restoration to reduce the number of people sent to the state hospital. What they found and are trying to do in California is get their county providers to treat people in their own communities if they don't need an inpatient level of care in the state hospital, and thus reduce the need for people to go to the state hospital by developing these community alternatives. I enclosed for the committee, and I won't go through them. If you go to the next couple slides, you'll see specific recommendations that came out of each state. So what Florida said, and then the next one has Kentucky, and then the next slide has, I think, Georgia, just sort of some of the different highlights from the interviews. So you've got that detail if it's helpful. But with that, that's the information I had. We're happy to answer any questions, however we can be helpful for Kansas as you move forward.
That was a lot.
I hope it was helpful and not just overwhelming.
Oh, and I'm not complaining about your presentation. It's just, but thank you so much for that. That was very informative from both of you. So committee questions. Representative Buehler.
Thank you, Mr. Chair, and I don't know if this is for Ted or Wendy, but as I was listening to you talk about slides 16 and 17 on the key lessons on contracting and oversight, I'm curious, and I'm sure the experience differs for the states that have done this, but, and you could throw Kansas in there. So let's assume that we are considering or going to take a look at privatization. What is, or is there an average length of time from the time that those states began to study the issue to turnkey operation? So is it 1 year, 2 years, 3 years? How long does it take to do this? I don't know if there's a best practice, is I guess what I'm looking for.
I mean, that's a good question. As I said, in Kentucky, all of that was sorted out before the build. It didn't, you know what I mean? So the, building a hospital takes a lot of time. A lot of last minute things can pop up. Yeah, so unfortunately, I can't answer that question. I do want to say one more thing should have said during our presentation too, is that there is a lot of emerging technology. And so I don't know what stage your build is in, but there are lots of things out there with new things with patient monitoring that are hands off for staff, and some ways to decrease administrative burden. So that's another thing to look at, but I apologize. I don't have an answer. Ted, do you know the answer to the question?
No, I know that the states that were doing the whole RFP process, they spent over a year working on all the rules and the specifications. What I didn't go into is both Indiana, West Virginia, before that Tennessee, spent over a year developing an RFP, put it out with all the requirements for treating people in the state hospital. And in those 3 states, the bids that came back for taking over full management were actually higher than what the state was figuring it would cost to run it themselves. And so none of them went forward with privatization after spending a long time developing the RFP and system requirements. I think Indiana, it came back to run the Richmond State Hospital, was going to be $3 to $5 million higher than the cost of the state continuing to run it. On the other hand, the benefits that Florida and Kentucky both said is not having to go through the state employment process to hire nurses and doctors, the flexibility to hire staff in a privatized system, really was helpful to ramp up, especially as they had to open units or if you had to close units or whatever. The flexibility of not having to go through state employment rules was a big benefit for the privatization. So it's, it may cost more, but it also gives some flexibility to make sure you've got the appropriate staffing in those systems.
Thank you, Mr. Chair.
Thank you for that. Representative Bryce.
Thank you, Mr. Chair. Just a quick question. I think it's Wendy, on page 5 of your presentation. I had a quick question. You had mentioned the admission assessments and determinations were conducted by a community provider so that there won't be denial of difficult patients or admission of patients that could be better served in the community. I was just wondering, is that typically CMHC or is that another entity that does an initial assessment? Thank you.
Yeah, in Kentucky, it's our community mental health centers because of the way our behavioral health center is structured and the contracts that we have in place. It could be somebody, but what works, from my perspective, it worked well with the community mental health centers because they are responsible for those outpatient services. So they have a vested interest in, we hold them accountable by contract for things like hospital admissions and readmissions and some of those same metrics that we do the hospital, so that the hospital and the community mental health centers both have, a dog in that race. So everybody, so they want to get it right. They obviously want to make sure folks get to the hospital who need that level of care, but they also want to be sure they're serving anybody that they can in the community in the least restrictive environment. So yes, in Kentucky, it's a CMHC. I'm sure it could be structured another way, but again, you just want to make sure what their interest is and is it in the best interest of Kansas first and foremost.
Great, thank you very much.
Mm-hmm.
Committee, further questions? Senator Erickson.
Thank you, Mr. Chair, and thank you. This is a lot of very helpful information. So I think this might be for Ted. You mentioned Missouri and placing people in university hospital setting. Could you give us a little bit more information about that and how that works?
Yeah, my understanding was, and this was in part when they had a major budget deficit a number of years ago, and they had a state hospital in Kansas City and also one in St. Louis, and both of those cities had major universities with medical schools and stuff, and university hospitals. And so what the state did was work with those universities to make sure they set up a psychiatric inpatient unit as part of the general hospital. And since it's part of a general hospital, it's not an institution for mental disease. It could bill Medicaid. And so what they did was they closed the acute units at their state hospitals. And instead, the community providers and system sends the people to the university hospital where they can then bill Medicaid for care. They reserve the state hospitals. I think their commissioner was saying they're almost entirely now forensic clients, so sent by the courts or not guilty by reason of insanity. But they also do some long-term care. So if somebody goes to the general hospital, the university hospital psychiatric unit, and after, I don't know if it's 30 days, 90 days, isn't still responding to treatment and needs continuing longer-term inpatient care, then they would go to the state hospital. For the initial acute, which often can be, 7 days or, a couple of weeks to get people stabilized on medication and then discharge them to the community. They've stopped treating those people in the state hospital in Missouri and worked with the university system and basically, shifting it to a non-IMD to help bill Medicaid for it. Instead of, they went to the state hospital, it was 100% state general fund dollars paying for that care.
Mr. Chair, it seems like that would also then alleviate folks sitting in jail waiting, for an assessment. I would think that would be part of a solution for that as well. Thank you.
Very good. Thank you. Committee, further questions? Okay, very good. Looks like no questions from the committee. Thank you again for your time and your expertise. We really appreciate that. We may have questions in the future, but Leanne can get a hold of you if we do have some more questions about that. So again, thank you.
Thank you.
Thank you.
Okay, committee, we'll move right along to Dr. Kevin. Is he here or is he WebEx? Okay. Kevin, are you there?
Can you hear me?
Yes, is this Kevin?
It is, and I
Okay.
am.
Very good. Welcome to committee. Thank you.
Thank you, sir. Good morning, special committee members, legislators, and guests. It's a privilege to be able to speak to you today. My name is Kevin Ann Huckshorn, and I am a national and international behavioral health consultant with over 40 years of working in mental health and substance abuse fields. I received my education at Florida Atlantic University, the University of Miami, Florida State University, and Capella University. And as a result of that, I am a clinician, a healthcare administrator, a researcher, and a published author. I've primarily worked in the United States for these years, but also have had the privilege of working in New Zealand, Australia, England, Scotland, Denmark, Finland, Canada, on mostly culture change in public hospitals and the reduction or prevention of violence in those same hospitals. I'm currently working as a behavioral health consultant for the states of Kentucky, Massachusetts, New York, and Vermont. I submitted my curriculum vitae, so I'll just briefly mention my work history for the committee. My work experiences have ranged from small public community mental health centers, where I got my start, to private for-profit hospitals, large public emergency rooms, state governments, the National Association of State Mental Health directors, where I spent 10 years, and so I'm very familiar with Mr. Letterman's work and Ms. Morris's work. I've also spent a lot of time in roles in public-private partnerships specific to the privatization of public state hospitals. I've also worked in terms of my actual discipline work as a nursing assistant, a registered nurse, a nurse clinician, an assistant director of nursing, chief nursing officer, assistant hospital administrator, hospital director, chief executive officer, and as a consultant in a variety of roles. And last, I was the lead in the developing of the evidence-based practice model known as the 6 core strategies to prevent conflicts and violence in behavioral health settings, which started during my work at NASHBID, became an evidence-based practice in 2012, and has continued to be utilized internationally for the very common problem of seclusion and overuse of seclusion and restraint, and the effects that the use of seclusion and restraint has on staff and patient safety. My experience with state government public-private partnerships began in 1997. I was currently in Florida, which is pretty much where I grew up, and I was invited to participate in the first state hospital partnership at South Florida State Hospital, which is in Pembroke Pines, Florida, Fort Lauderdale. South Florida State Hospital is a 350-bed adult facility that had been experiencing over decades multiple lawsuits, untimely deaths, discharge and admission gridlock, which means you can't discharge, and of course, if you can't discharge people from a hospital, you can't get anybody new in. Excessive use of seclusion and restraint, excessive patient and staff injuries, and it was not accredited by the Joint Commission. None of the hospitals in Florida were at that time accredited. In 1997, the Florida Legislature ordered Florida's Health and Human Services Department to turn over the management of this facility. And so while I was currently, or had just been currently a state employee for Florida, I was asked to help respond to the request for proposal. And this was, I think, a very important step by the winning provider in that project. They reached out immediately to get partnerships with some of us who had extensive state hospital experience on the state side, so we could really help craft the proposal response. I had a lot of concerns about this. Like I said, I had worked for the Florida State Alcohol, Drug Abuse, Mental Health Office for a number of years. I was the Florida nurse consultant for all 7 of Florida's state mental health facilities. And I did that work for over 2 years, driving around Florida, spending weeks and months at those state hospitals, trying to promote promising and best practices and working with staff culture, nursing vacancies, which has always been an issue, violence prevention, and those kinds of things. After that work in Tallahassee, I then became the state's district program manager for Broward County, which is the large county above Miami-Dade. And I was in that role for 5 years, and that is where South Florida State Hospital was located. So I was very conversant with what was going on at South Florida State Hospital. When the state announced that they were going to privatize this facility, there was a lot of uproar. The state was not particularly supportive of this change. Certainly the unions were very unhappy. The local media, ran a number of stories about the poor outcomes that would happen if a state public facility was turned over to a private company. But I decided at that point that this was worth participating in because I thought I'd either learn it would work or I would learn all the reasons why not to do it. So after the company, which was Recovery Solutions, back then it was called Atlantic Shores Healthcare, back at the time, I ended up taking on the position as the assistant hospital director and later became the director of nursing. So that hospital turned over on October 31st, I believe, 1998. And on that day, Recovery Solutions, the contractor and the leadership team came in and took over that facility. In retrospect, this was a life-changing experience for me. not only were we able to turn around that facility in 2 years, while keeping the majority of the staff, the state staff, we were able to completely change the culture of care, the environment of care. We built a new hospital. We completely rewrote the job descriptions, the competency expectations of staff, and then provided significant training. We also became much more aggressive in terms of the clinical care provided, and again, built a new facility. By the end of that 2 years, South Florida State Hospital also became the first state hospital in Florida to receive Joint Commission accreditation, which was part of the contract and should have been, and was a real feather in the cap of the staff that really worked so hard to make that happen. During those 2 years at South Florida State Hospital, those first 2 years, we were also able to shorten the patient's length of stay from approximately 9 years, length of stay at the hospital of 9 years, to less than a year, and that's current. Open up the admissions completely again, so we got rid of the gridlock, and reduce the use of seclusion restraint by 95%, and the concomitant reduction of injuries of patients and staff, because people most commonly get injured when they're putting hands on people in the attempt to try and put them in seclusion or restraint. So those numbers went down significantly. The state of Florida was extremely pleased by this turn of events, and as you know from probably your information that you've gotten from Nashville, that the state of Florida went on to privatize a number of additional hospitals. So from that experience, I took the position as the director of the National Technical Assistance Center for State Mental Health Planning at Nashville, where we just heard my two colleagues speak. This was a federally funded position, and I served in that position from 2001 to 2009, and was able to parlay much of what I'd learned at South Florida State Hospital into best practices for other states, including the reduction of seclusion and restraint, the launch of the use of peer support specialists, which we did at South Florida State Hospital, and was a very valuable addition to the workforce. The implementation of trauma-informed care principles, learned a lot about the recruitment and retention of nursing staff, and empowering the people that we serve in state hospitals with a voice and choice in their recovery paths, which tends to really help participation in treatment and improve outcomes for people that are getting discharged. After that time, in 2009, I became the commissioner for the Division of Mental Health and Substance Abuse in Delaware, kind of the type of role that Ms. Morris talked about in Kentucky. My focus there was meeting the terms of the United States Department of Justice settlement agreement, which was going when I got there. And we spent a lot of time at the single state hospital in Delaware, who had, at that point, it was about a 200-bed facility, had over 100 people that had been there over 20 years who were not moving. And we were able to successfully discharge over 100 people in that state hospital over the 5 years that I was there. We talked about privatization, but we could not move that ball. But because of my experience and those of my team members, we were able to implement a lot of privatization type efforts to really change the culture in that particular hospital. From there, I went on to work with Recovery Solutions again in another public-private partnership in Massachusetts. This partnership was ordered by the Massachusetts governor back then, Governor Baker, to privatize the Department of Corrections run Bridgewater State Hospital, which is a 275-bed facility for male adults. who have committed serious crimes in the throes of a mental illness, and who generally came to that hospital through the prison or jail systems in Massachusetts. And again, this partnership turned out to be incredibly successful. Bridgewater State Hospital, if you Google that facility, you will find that it also had multiple lawsuits, a number of really kind of shocking deaths. The Department of Corrections was your typical Department of Corrections, and they really didn't have the expertise to run a mental health facility. They did the best they could, but they just didn't really have the staff or the staff competencies to do that work, and the governor recognized that and turned this facility over, and that happened in 2017. Again, within 2 years, this partnership proved to be successful. We were able to reduce these seclusion restraint by 93% and 97% respectively, with the resultant decrease in staff and patient injuries. We were able to implement person-centered treatment planning, add large numbers of nursing staff, create a much safer environment of care, because we switched out the correctional officers with specially trained behavioral health safety technicians, greatly expanded the clinical opportunities available to the people that were in care, and improved the environment of care as best we could, considering it was a very old prison setting. I also, after that, went up to Alaska with Recovery Solutions to try and help them maintain their CMS certification, which they were in jeopardy of losing. I was there for about a year. That proved to be successful. We were able to assist that state in retaining their CMS certification. And then COVID hit, and I came back home to North Carolina. So I guess in summary, I first want to say that I strongly support what Ms. Morris and Mr. Lauderman talked about in terms of the recommendations, with just possibly one caveat. The statement, or that it's good to try and get local providers to provide state hospital services if you can do that in a privatization project. It's true, but the problem is that the learning curve to actually run a state facility is quite high. And as part of Recovery Solutions, when we, in Florida, in Massachusetts, in Alaska, we were not particularly local, but Recovery Solutions has a long track record of immediately engaging local community mental health centers, local providers, National Alliance for Mental Illness, Mental Health Association, the peer support networks, the universities that are around that particular facility, to certainly get that kind of local input. Again, it's difficult to find companies like Recovery Solutions who has the kind of depth and breadth of the competencies in taking over large public organizations. So I just wanted to mention that. And I think the last statement I'll make has to do with nursing staffing. Being a nurse for so many years and being so involved in recruitment and retention efforts in so many different hospitals over the last 40 years, in my opinion, the recruitment and retention of high quality nursing staff is complicated. And it's not a simple, there's no simple solution to it, but some of the key factors that I found significantly helped was senior hospital leadership involvement. And I don't mean, once every 4 months meeting with the nursing staff. I'm talking about walking rounds. I'm talking about open door policies. I'm talking about significant support to nursing staff through highly qualified supervisors who both know how to support staff and also how to coach. the ability to recognize performance in nursing staff, which is very difficult to do in state public systems because often those things are prescribed in CBAs, the union agreements, bargaining agreements. So you can't recognize or reward staff for excellent work. You also want to be able to pay for performance. And sometimes that even means, merit increases that have nothing to do with how many years you've worked in the facility. You've got to be able to reward good performance. You also want to try and minimize contract staff who generally have much less of a engagement in the well-being of the facility just because they're there for such a short time. And then flexible scheduling is also pretty critically important. So I'll stop there and see if there's any questions. I'd be glad to answer any from the committee, legislators, or legislators who are the guests. Thanks.
Very good. Thank you for that. It was a lot. Again, committee questions. Dr. Kevin, it looks like you're off the hook. I don't see any questions from the committee. So, but we may have some questions later on that Leanne may reach out to you and look for some answers for, if that would be okay.
Of course. Yes, sir. Thank you.
All right. Thank you. And thank you for your time. Have a great day.
Thank you.
Okay, committee. Wow. Next, we have Leanne. Leanne, thank you. Welcome to committee, and thank you so much for being here.
Sure. Good morning. As he said, my name is Leanne Thone. I'm a senior research analyst at KLRD. In the testimony for today, there is a KLRD memo that is about the state mental health hospitals and privatization. This is mostly just to give you a little bit of context about what the law says right now about privatization in Kansas. And so you know what that situation is as well, and then what is happening currently at the state hospitals. I won't go over the brief overview of the two state hospitals because we heard a lot about that yesterday. But I will start with the context for the law that got passed in 2016 and 2017. So in that section about decertification at Osawatomie State Hospital, it goes over what kind of led to that decertification, which happened in 2015, at the end of 2015. It was mostly an over-census issue, so there were too many patients for the number of staff that the hospital could handle. As a response to the decertification, the hospital made improvements, but the legislature also responded to this. There were two budget provisos in 2016. These were in SB 161 and SB 249 that prohibited KDADs from expending any money appropriated for the relevant fiscal years to privatize the operations of LSH or OSH without prior specific authorization in an act of the legislature or an appropriation act. And then that legislature also passed a bill which codified that prohibition, which is at KSA 753373. In 2017, that statute was amended by SB 32, and this basically just expanded that prohibition to clarify that no state agency may enter into any agreement to privatize OSH, LSH, or any state-operated facility that provides mental health services without prior authorization from the legislature or an appropriation act. This applies to outsourcing or privatizing of all or any part of these facilities, including transfer of bed capacity to another facility, but it did not apply to agreements in existence prior to March 4th, 2016, or renewals of agreements substantially similar to those. And then there's a little bit about the recertification at Osawatomie, just to kind of close that narrative. But that is the statute that currently is in effect. The last section of this memo just gives you a little bit of information. There are certain services contracted out at the state hospitals, at LSH and OSH, food service for patients, some laboratory services, a portion of the nursing staff, as we've been talking about contract nursing, and temporary physician coverage are provided through contracts with private companies. At the Kansas Neurological Institute and Parsons State Hospital, the hospitals that serve the IDD community, intellectual and developmental disabilities, pharmacy services and medication supplies are contracted out. And all state hospitals use outside medical and dental providers for specialized services that cannot be delivered by medical providers on staff or for more acute medical services through inpatient hospitals. If there are questions about that portion of this memo, I would respectfully defer those to the superintendents of those hospitals to respond to that, because I am not an expert in that area. But that is a little bit of information about the statute as it stands today.
Very good. Thank you for that. Committee questions? Senator Clifford.
Thank you, Mr. Chairman. So you mentioned prior agreements before March 4th, 2016. In Garden City, we had a unit in private hospital, not for profit, that was turned over to our community mental health center. Of course, they lost so much money on it that they had to close it. Would that be considered a private contracting arrangement with Larned, or that's just?
I am not sure what the answer to that question is. I'm not sure if anybody here knows that. Would you like to come up and answer, or?
I mean, the statute speaks to run at State Hospital and Osawatomie State Hospital, and that was a community.
Right, okay.
Okay, I can hear Amy, I understand.
Okay.
So, thank you.
Yeah.
Thank you,
The
Mr. Chairman.
statute speaks to state facilities and not private, so.
Thank you.
Senator Erickson.
Thank you, Mr. Chair, and I apologize. I probably should know this, but how often, I'm looking at the recertification information, how often are the facilities recertified from CMS?
I will also defer that question to KDADS potentially. Every 3 years is
Every
what
3
I'm
years.
hearing.
Okay, so the dates cited in this recertification issue were 2017. So if it's every 3 years, I'm assuming there have been no issues since the issue in 2017. Is that correct?
I did not run across anything in my research for this memo, but I cannot just say that definitively.
Committee, further questions? Were you going to elaborate on, I'm not aware of any issues as far as dealing with CMS certification. You would have thought we would have seen it through the budget process. You know, when we lost that certification, the first year we had to pony up $9 million to fill that budget gap because of lack of Medicaid. So I think we'd see that in the budget. So anyway, thank you. Any other questions? Senator Clifford.
Mr. Chairman, thank you for a second opportunity. I wonder if anyone in the room could explain this IMD concept, Institution for Mental Disease, and why they can't bill Medicaid. I don't know if Scott can handle that, or I don't understand that.
Scott?
Scott Bruner, Deputy Secretary for KDADS. The IMD rule. So federal law says that if you're an adult in being treated in an institute for mental disease and you're between the ages of 19 and 64, Medicaid can't pay for that treatment or those services. So it's a payment restriction that in other settings or in other Medicaid programs, Medicaid pays for inpatient hospital stays, outpatient hospital stays, psychiatric treatment, mental health treatment. That's pretty typical. But the federal law carves out this one location that you cannot use Medicaid funding to pay for treatment for adults in that age range in that setting. Which then begs the question, what's an IMD? So the federal law also defines that an IMD as a facility or institution that whose primary purpose is the treatment of mental disease for adults. And if the way that's operationalized is if it's more than 16 beds, then it meets that criteria of being an institute for mental disease. If you had an inpatient psychiatric unit that had 15 beds in it, it wouldn't be. If it had 17 beds, or 16 or 17, it would be. The other nuance of the IMD rule is that comparison to determine whether something is a large enough part, where treatment of mental illness is a large enough part of what that facility does, it looks at the total licensed bed count. So I think the example that our NRI partners mentioned, or for in a university setting, if you take the University of Kansas Hospital, I don't know how many beds they're licensed for, but let's say it's 1,000, and they've got a 20-bed psychiatric unit, which by itself would be an IMD, but because it's 20 beds within 1,000, it's not a large enough percentage that it doesn't trigger that IMD exclusion. So I think that pretty much is the answer. It's a payment restriction that applies to certain types of facilities, and the way they're defined, and it's entirely based on the age of the patient and the size of the unit.
Follow up, Mr. Chairman? Yes, thank you. So how are we at LSH and OSH and New South Central not an IMD? Surely we may bill Medicaid.
There's some, so we can bill for, we can't bill for adults that are in that age range, but we can bill for other adults that are either over or, we don't admit that many 18-year-olds, but we could. But so it's for adults that are older. So we are subject to that exclusion.
Is there block grant funding then from the feds, or have they abdicated this to the states? I'm flabbergasted.
I'm not going to use the word abdicate. You appropriate, we build our budget around, and you appropriate state funds to make up that difference.
Thank you for your answers. Thank you, Mr. Chairman.
Can I add one other? I feel like I'll leave that with that. So we are in the process. States can apply for something called an IMD waiver. So we can request that CMS give us authority to from that exclusion through a Medicaid waiver process. And some of you are more familiar with that than others and in your service on budget committees. Kansas has an IMD waiver for substance abuse services, but not for mental health services. CMS grants those separately. We are in the process of working on an application for an IMD waiver for behavioral health services. So then we would open up to that age range for units that are larger size. Then our other obstacle would be you have to be an adult who's eligible for Medicaid. And there aren't, because we're not an expansion state, there aren't as many of those adults in Kansas as in other states, but there are still adults, 1964, that are eligible for Medicaid, that if we had a waiver, we could receive Medicaid funding for. I think that rounds the whole, I didn't want to leave that we aren't working on it, but it's a complicated process to get an IMD waiver, and we've been working on it for a number of years.
So following up with that, our Medicaid rules are $9,000 a year as far as eligibility. So, and you're in a facility, how much money are you making? I mean, it seems to me like about anybody in there that had been in there a year would qualify for Medicaid under our current guidelines.
So the other part of the IMD exclusion is while you're a patient in an IMD, you're not eligible for Medicaid because of the exclusion.
Correct, but the waiver would allow that.
The waiver would allow that, yes.
So I'm saying I can't imagine anybody that's in there not qualifying for Medicaid if we received the waiver. They would have to make more than $9,000 a year. How are they going to do that?
So I've exhausted my knowledge from my experience as Medicaid director and in this job. I haven't thought through the implications of what we would actually do if, once we get the waiver, how we would process applications inside the hospital setting. We don't do that today.
Okay, I'm
working on the
brainstorming as far
8
as-
problems that are immediately in front of me and not the one that's a year and a half away. But it's a great question. I'll give it more thought. But
And then another thing to piggyback, so once they turn 64 or 65, then Medicare, are we able to bill Medicare for those folks that are
Yes.
over 65?
yes, if they have Medicare coverage, yes.
Wow. Representative Bryce.
Thank you, Mr. Chairman. Just to piggyback on that, the Medicare coverage, is that a cost-based, like we have at critical access hospitals, or is that more a DRG-based Medicare? In other words, are we reimbursed to cover all the expenses for those patients? Just curious, because I think yesterday, particularly Lindsay, I think it was, that spoke about several long-term patients. I don't know how many you had, but it seemed like a large number, and I assumed they would be Medicare. And I don't think we've discussed too much this business side of reimbursement from Medicare, private insurance, et cetera, et cetera. I assume you don't have a lot of private insurance reimbursement. I could be wrong. The state's funding majority of this, but these Medicare patients over 65 are the ones that are interesting to me, because it seems like there could be a revenue stream from that would be a positive cash flow for the state even. And I was just curious about that, if you have any comment.
There is, we bill Medicare A and B. We establish a daily rate that's part of our cost reporting process, and we do bill Medicare A and B. There are some limits on days, I think, that we trigger like any other hospital would. We do have some patients, particularly at Osawatomie, it comes up, or we've talked about it more there, where they actually have Medicare Advantage. So they're not in the traditional Medicare program, and we need to then we negotiate contracts with their Medicare Advantage coverage. But we bill for what we can for those patients as well.
Okay, if I could, so you're not billing Medicare. It's not cost plus type of. It is.
It is not.
It is
cost
not.
plus.
Okay. So these staffing agency extra expenses we have aren't folded into that anyway.
They are our daily rates based on our cost to deliver care. So we do, the cost of staffing is one of those costs that's part of the calculation. So it is reflected in our daily rate as it moves through that formula to provide staffing.
Do you recall just briefly about how many Medicare age patients are in these long-term patients are in the facilities? That was several hundred, wasn't it? Was it, if I remember the number from Lindsay?
We could get that number for you.
Okay,
how much we do. We do.
But it's a significant number anyway. Okay, thank you, Mr. Chairman.
Representative Reeves.
Scott, along those lines, so if someone has not applied for Medicare, wouldn't they have to apply for SSDI? Just a different. It's a different process, and there's a lifetime, right, on, is it Part A, Medicare Part A? I think there's a lifetime days, bed days or something like that.
I'm going to phone the social worker on our team.
Way to go, social workers.
Ashley Byram, Superintendent, Osawatomie State Hospital. So in regards to that, yes, we do, when our patients are at the hospital, we will apply for both SSD and SSI to see which one they would qualify for. Most of our patients are going to qualify for the SSI, but they will not be able to obtain those funds until they're discharged from our hospital. In regards to your lifetime, sometimes based off of individual's diagnosis, they're only approved for a certain amount of days covered by insurance. So if you, let's say you're, have a diagnosis of schizophrenia, you'll be approved for 21 days for your lifetime for hospitalization.
Thank you for that. Committee questions of Ashley? Seeing none. Thank you very much. Committee, further questions? I guess that when we get past Amy, we'll kind of talk. I have some questions written down more for some information gathering about, it seems to me like we've gotten this far and we really don't know who we're talking about and how many people we house, in what categories they are. And so I think probably to make the final deal, we need to know what we're actually talking about here in the number of all the categories that we house. So anyway, I'll be asking that question. But in the meantime, no stranger to most committees, especially in the mental health realm and stuff like that. Amy Campbell, welcome to committee.
There we go. Let's see. So I am going to kind of divert from my written testimony quite a lot just because of listening to everything that's been here, and I don't want to be repeating things that you guys have already gone over. The way you opened your meeting this morning was so perfect. I have been working for the Kansas Mental Health Coalition for, I say now, more than 20 years, just because I don't like to count all the years. That has put me through the period of time when Kansas was seriously investigating privatization options and ultimately decided not to take that path. So I hope that what I share here can be helpful to you, just because I kind of have that history of having been around during that time. What you talked about this morning in really identifying sort of your populations and the big issues, and the fact that this is a big, big topic should not be a reason to not go right at these individual problems that you're trying to solve. It's overwhelming, without a doubt. However, you have people in the agency who have really tried to wrap their arms around all of this. You have the reports of the 2018 and 2019 mental health task forces. You have the Special Committee on Mental Health Modernization and Reform. All of the data collected and recommendations from these bodies are still pertinent today. The Kansas Mental Health Coalition supports those recommendations heartily, and we commend the agency for pursuing a multi-pronged approach with the support and funding authorized by the legislature to go at some of these solutions for the full continuum of care. What you have done is to invest in multiple aspects of our system of mental health and addictions care in order to look at the big problem. And the big problem was the pipeline, the populations, the fact that we were funneling almost everyone into our state mental health hospitals at that time. Why were we doing that? Because we had been starving the mental health system for decades. We had starved our mental health hospitals. We were understaffing it. We were putting people in hallways. We were crowding rooms. We were flouting the certification requirements. The decertification of Osawatomie State Hospital was not a surprise. It was fortunate that that came at a time that we were then able to really dive in and do problem solving and avoid decertification at Larned as well. So going forward, your recommendations really need to be looking at overall health care, overall quality of care, and overall workforce issues, which you heard a lot about yesterday. You want people to want to work in these facilities, and what are the things that make them want to work there, and what makes them want to work there for a long period of time? How do we invest in them so that working in the state mental health hospitals is a lifetime career, which is what it used to be? So I'm going to kind of jump ahead and talk a little bit about, if you can, look at the recommendations that came out of those task forces. They are pertinent today. The expansion of the number of psychiatric beds in the state is still a goal. All of the investments that have been going on in the state hospitals, unfortunately, really have not expanded our capacity that much. We are still operating with not enough beds in the state of Kansas. But we have made great gains in providing alternatives before someone comes to the state hospital, not the least of which is the Crisis Intervention Act that is finally being implemented to open crisis intervention centers. Some of you who are on the pertinent committees know we have the crisis stabilization centers units already. The crisis intervention centers actually can take involuntary and actually can hold people for up to 72 hours at the local level, which diverts admissions from your state hospitals and drastically improves the ability of the state hospitals to meet their missions as well. Plus, it's just better for people. So you will see, last year there was a great deal of conversation, and there was a little bit of a holdback on funds for the crisis centers. I encourage you to revisit the lottery vending machine money, because that funds your crisis centers, and some of that money can go to those crisis intervention centers. Investing in our state hospitals as the safety net is not a choice. You have to do it. So you have to decide what you want them to be doing and where, and what's the best utilization of the state funds. In no way does the Kansas Mental Health Coalition support eliminating or abandoning our state hospital campuses and the incredible work that they do there. But you should be looking at what you do in those locations and if that's the best way that you want to invest your money. One thing that nobody ever wants to talk about, it's a hot potato, and I would leave it to you, Mr. Chairman, to see if you want to make recommendations in that area. But the legislature should get back into the business of investigating the sexual predator treatment program, how much money we spend there, and if that's the best way to spend your money, and if that's where you want them to be. There is an issue there. There are little things that could be done, not the least of which is you have some people there that are very elderly, and is that the least expensive and the best place for them to be right now? Just an option. So as you look at public-private partnerships and privatization, Kansas invests in private community hospitals, in partnerships, and in private psychiatric hospitals in partnerships through the State Institutions Alternatives Beds, the SIA. Part of the reason is what you were just hearing about is the IMD exclusion. Hospitals can bill Medicaid for these people if they are not an IMD, and so the more patients that we can refer in that direction, the better that program can be supported, and that also diverts admissions from our state hospitals while also keeping people closer to home. And these kinds of private partnerships are very beneficial over time. We have been recommending since, I think, 2015 that we submit this federal waiver application for the IMD exclusion rule for mental health. I want to point out it's not the agency's fault that that hasn't been done yet. When the federal government finally decided that they would allow this, they directed states to start on the substance use treatment side. And so they were very slow to get the rules out and all of that. Identifying the difference between your acute patients, your forensic patients, and your longer-term patients is key because the options for funding that treatment are entirely different. You can't mix and merge your solutions there except in the sense of workforce. And that's why the new hospital has half the beds committed to the forensic side and half the beds committed to the acute mental health treatment side. It's important to recognize that when we recertified at Osawatomie State Hospital, the majority of those beds there are not certified. We only certified the acute care unit. And so all of those beds there, they're not eligible for Medicare funds. They would not be eligible for Medicaid reimbursement. And they're typically not reimbursable by a lot of private insurance or other resources because they're not certified beds. That lends itself to the point that we have to continue to be looking at our Osawatomie campus and the physical reforms that have to be made there and what we need to be doing on that campus to improve the care there so that we can have more certified beds, which are better reimbursable beds. If they're not certified, you're funding them with state money. The other thing that happened to the state was with the Affordable Care Act, the DSH payments started going down to the states, and we use DSH payments to fund state hospitals as well. So implementing the recommendations of the Mental Health Task Force included a comprehensive plan to address the needs at all levels and all settings, including adding inpatient capacity up to a total of 221 beds over 5 years. Well, how do you do that? Obviously, there was an idea at one time of building a new 200-bed state hospital. That is not the direction that we think the state should go. We think that you can do that through many of these partnerships and a combination of resources across the state, expanding the funding that goes to local communities, to Western Kansas communities, to Central Kansas communities, to have crisis intervention units, to have smaller specialized mental health units available that are not IMDs and that are available for reimbursement. So when you look at the privatization issue, I think it's important to note that South Central Regional Psychiatric Hospital Advisory Panel that was implemented for pre-opening of your South Central Kansas Mental Health Hospital recommended against privatizing the operation of that facility. Why do the task forces, why do these entities shy away from privatization? Well, I think you've heard a lot of it in the testimony that you've heard already here. The issue is that the operation of a state hospital is different than the operation of private units. And the issue at hand is, and I got the opportunity to visit Florida when Kansas was looking at privatization. Most of the reforms that we saw down there that they were able to implement were things that Kansas was already doing. The way that the private unit was able to operate and continue to have their contract there is that they operated under a per-bed system where they got their costs and then they built in their profit margin. So all of the things that a private contractor will have to do to fully staff a hospital are all the same things that the state has to do. The difference is you then build in a profit margin or you don't have the contractor. And so I didn't include in here the many, many articles that you can all find about what has happened, the experiences have been across the country. I wanted to, but the problem is they mention various corporations, and I don't think that's fair. The difficulties that those contractors run into in running these units are the same as the ones that we are running into. And so they end up with certification problems. They end up with being sued for deaths and illnesses and incidents of violence. They end up with all of those same issues that occur. So I would encourage you to go out and do kind of a search for yourself and look at that, and you can find that information for yourself. I think you heard some really good recommendations this morning about if we chose to go down a privatization route, all the stuff that you have to have in your contract. One of the biggest problems with privatization of things of a state mandated function is transparency. When you contract with a private company to do that, you don't get the transparency, you don't get the information, you don't get the data and the quality information that you currently get from facilities that you run yourself, and that is very important. One of the examples that I would give to you is that Kansas privatized our smaller children's hospital units. That's great, they seem to operate very well, but you do not receive annual reports on them. You do not receive data about the number of patients that go in, the number of patients that go out, what their success rates are, what the recidivism is. You don't get any of that anymore because it's all been privatized. So I don't want to go through all of this. So I just wanted to kind of say that as we look at workforce issues moving forward, I think it's absolutely essential that we be looking at making these desirable careers, investing our state dollars into the employees, their healthcare plans and benefits, and their training and opportunities for the future in growing their own careers, to develop that workforce that stays in the careers instead of quickly moving on. One of the areas that we can look at in healthcare in general is that healthcare plans for people who work in privately owned hospitals are actually not very great. The state has an opportunity to offer the state employee health care plan to people who work in these state facilities, which is a great incentive for them to want to work in these facilities. And diversifying your employee base and bringing in peer services is another way to build our workforce within these facilities. Some of that is currently being done. It's slow. It's not something that happens overnight, but it's been very successful so far. So the Kansas Mental Health Coalition really recommends this multi-pronged approach, staying the course, working the way that Kansas has been in moving forward. You, the legislature, has already built into your plans for the state, South Central State Hospital, that it has the opportunity to expand in size in the future. We believe that you should take a close look at the units that are operating specifically for the functions they serve. You can't generalize hospital populations, but you know that what you have to pay at Larned has to do with the fact that there are correctional facilities out there, and you have to be able to compete with your own state jobs out there in order to keep people in those positions. And so that's important to look at that and see what it costs you to operate that there, and if you need to move things around. Opening additional regional opportunities in different parts of the state is also part of this solution, and we're only in the beginning stages of that right now. At the end of my testimony, I've included the actual recommendations from the 2018 Mental Health Task Force report. I'm not going to go through those, but I thought that people might like to see that historically in order to see how the agency has been moving forward with different aspects of this, including the private contracts with community hospitals to provide beds and to provide support for serving these populations in the best way possible. Finally, anything that you do has to have quality measures included. And those quality measures, yes, they include staffing ratios, which we know that if you look over the years that privately operated facilities under contract with the states typically don't have the staffing ratios that are desired. And we want to make sure that those are included in anything that you would do, knowing, of course, that they're very hard to achieve. Furthermore, the quality of how people operate. Are they able to get services in the community when they leave the hospital, and how successful are they in the community? At the end of the day is the real measure that you want to be looking at. You want to be thinking about, if it was my brother in the state mental health hospital, how do I want them to be treated, and what should their care look like, and what should it look like when they come out? If my sister is a nurse in that hospital, how do I want her to be treated as an employee of that facility at the end of the day? And if my son is going to be a mental health tech at Osawatomie State Hospital, are those the job opportunities that I think he should have, and is he getting the benefits and the treatment that I think that would encourage him to work there as a career? So with that, Mr. Chairman, I hope that this is helpful. I've tried to just kind of pinpoint some of the things that the committee has talked about without repeating some of the really good information you've already received.
Yes, thank you. Thank you, Amy, for that. If our eyes weren't glazed over by all the information before, you just helped us out some more.
Job completed.
And we appreciate that.
Thank you, Mr.
No,
Chairman.
committee questions. Who does? Can I go to her first? Senator Holscher,
Yes, thank you.
go ahead.
Yeah, thank you so much. Amy, thank you for that presentation. Thank you for that review in terms of kind of the history behind some of the aspects that have been looked at in the past. You mentioned the sexual predator treatment program, and I won't take up time here with that, but I would like to talk with you more at length about that. I've actually had a couple of people mention that to me in just the past couple of months in terms of concerns and issues there. What I wanted to ask you about, though, really, you mentioned that this used to be a lifetime career in terms of working in our hospitals. You mentioned the healthcare plans for the employees aren't great at this point. Can you give us a few more details in terms of, what makes this career look better to a potential employee?
So my point about the healthcare plans is that in talking to people, and I have many family members who work for community hospitals and for private hospitals. And I can tell you that one of the things that is absolutely shocking to me is that a nurse in a community hospital, doesn't necessarily have a great health plan. So if we want to attract people to be working in state hospitals, this is a great opportunity. You have the state employees healthcare plan, which is good coverage, which is a good plan. We should be really pushing that to people who have families and saying, come with us and we're going to invest in you as a person. I think that we have many career employees at the state hospitals who have reached their retirement age. And so that's also been a big issue with staffing at those facilities. And so talking to the people there, which KDADS has done, about what is important to them, and they've told you that flexibility in hours is important to them. The benefits that they get are important to them. Opportunities for advancement and training are important to them. And so we need to listen to them and make those investments in those areas. I do think that state jobs are going to be attractive to people again. We are in a time where I believe we're moving past that time where everybody can just get a job at the drop of a hat, right? So state jobs are attractive to people. They can be attractive to people. And these are the things that we should be investing in to make them want to come. The front end of education and academic investment that we have started in this state in the field of behavioral health is very important, and it was only partially funded last year. But this is an area that can grow, that can bring people in who then can repay the state for those investments by working in CCBHCs or state facilities.
Thank you so much, Amy. I appreciate it.
Very good. Thank you for being here. Senator Clifford.
Thank you, Mr. Chairman. Thanks for being here, Amy. Good to see you again. You seem to be focusing a little bit on the community, which I appreciate a lot, because one of my concerns is that we'll move services further from western Kansas. And you're saving Lindsay a little bit, because I've been texting her about what's on my mind. I know we had a unit in Garden City, for instance. Common Spirit, our Centura at the time, closed it. We picked it up as at the Compass Mental Health Center, and we lost $600,000 trying to run it. But within a 100-mile radius of a place like Larned for psychiatric services, I can imagine Garden City, Hayes, Salina, Hutch, Pratt. Surely that could be, with state investment, put back in the community and let Larned do what they do with the most acute, maybe keep the forensic piece. But, you know where the bodies are buried. Are there old units out there that besides Garden City that have been decommissioned that we could invest in?
So when I started working for the Kansas Mental Health Coalition, which we agree was in ancient history, there were more than 30 psychiatric units across the state. And now, and then fast forward to 2017, I think in the Mental Health Task Force report, there's like 8 that aren't strictly geriatric. So why did that happen? The state partnerships that the contracts that KDADS will have with private hospitals and community hospitals, the state institutions, alternatives contracts and stuff are very helpful to operating those units. But the bigger issues for those kinds of units are access to psychiatrists and the mental health professionals to run them. Additionally, now I'm going to throw out another hot potato concept that legislators don't like to talk about, is insurance coverage. If a community hospital psychiatric unit has to fight tooth and nail to be paid by a commercial insurance entity for the patient that they've cared for 7 days, it makes it very difficult to operate a unit. And unfortunately, that is a reality of life today.
Follow up on that, but and I absolutely agree. We've heard talk here, though. We can get into other labor markets. The Garden City market, the Ellis County market, and the Saline County market, Reno County. So it seems like the state ought to find a way to pay for those facilities beyond insurance issues so that they can be brought back into the community where there might be a better chance. That there's a developing consensus here that we're tapped out in getting a workforce in Larned, where despite all of Lindsay's great efforts, we may have peaked or are close to it. So I think if we could fund getting those community units going again, it would be a great advantage.
So that I would direct you back to the Community Intervention Center option. I believe that Hayes will be opening one soon. Can anybody confirm that for me? I believe that Hayes will be opening a community intervention center very soon. That is something that event is for acute mental health crisis, right? Someone who's in an acute crisis, to take them in at that stage. I don't know if there are options further west in Garden City. It depends on the population. It depends on what that CCBHC has available to them and what they can do to operate such a thing. But that might be an option in that area.
Thank you. I'll have that conversation with Lisa Southern. So thank you, Amy. Thank you, Mr. Chairman.
Senator Rose.
Thank you, Mr. Chair. If it's okay, I have some questions for the two superintendents to expound on what Ms. Carter said.
You'll hold on just for
Sure.
a little bit. We're going to do question and answers here, or questions back at, after we get through grilling Amy properly.
I liked your idea, Senator.
So there are some time here just before lunch that we'll have questions for, because I think I have a ton of information that I'd like information to be gathered. So anyway, hang on just for a second here. Representative Ruiz.
Amy, when, I can't remember now who was the person that was making this, that was talking about Missouri, where, you know, the acute, at their state hospital, the acute beds were transferred to the community. And I'm assuming that was Truman Medical Center. It's now called University Health. And they've got what almost looks like a state hospital on their campus. What are your thoughts about that?
So Kansas, when Kansas was looking at privatizing, building a new state hospital and privatizing, they had in-depth conversations with the University of Kansas about how much more of a partnership could be created there to take on more of the acute patients. And again, you know, there's a difference between the acute population, there's a difference between the longer-term population. I think all of that has to be crystal clear, because how those services are paid for are different. What I will tell you is that when the Mental Health Task Force was convened, Missouri came and spoke to us. And they had problems within their system. They still had workforce problems. They had major problems with the fact that sometimes when the crisis was occurring in South Central Missouri, the only acute bed or emergency room entry for that person was in Northwest Missouri. Now, who transports them? So I don't view what they did in Missouri at that time as very different than what Kansas has done with its alternatives beds with community hospitals, because we are able to direct people in different parts of the state to those community-based units that are there. And I don't know, do we have an SIA with KU anymore? We do not. So, and I can tell you that it was days and days of testimony in the task force about why hospitals don't want to partner to serve these populations, not the least of which is the lack of private insurance coverage, the issue of once they take them and then they decide that that person is too violent and it needs to go to the state hospital, are we able to do that, or are they going to be put on a waiting list and be left there because they're actually in a safe space? There are many things that go into those decisions. And again, the crisis of they're having enough trouble hiring the professional staff that they need to serve the people they already serve. So I would say that what Missouri did isn't all that different than what Kansas is already doing, and except that they eliminated their acute beds, which then eliminated their safety net option.
Thank you, Mr. Chair. So another question I have is, it has to do with the assessment piece. So right now, the community mental health centers are the gatekeepers to the state hospital. So there are clinicians who, they call them screeners, they come in and they do a screen and they deem whether the person is appropriate or not, and or they help with the involuntary process. Sometimes what I'm hearing is that a person could probably stay in a local psychiatric hospital unit, except that the physician is adamant that they can't do anything more for the person. And I've not heard of any kind of training for psychiatry staff and APRN psychiatry staff regarding really what does it look like when somebody needs an involuntary commitment? Do you say anything about that?
And again, we heard a lot of testimony about these issues, and you might have some folks from the hospital association, the hospitals that have private psychiatric units, come and talk to you about this need for being able to send someone on to the state hospital, and how that needs to be a very open and fluid and process that has a lot of options available to it. The issue is that in an independent psychiatric unit, the resources that they have to them and the acuity of that particular patient, how many eyes they can have on that person at any given time. Sometimes you have people who come in who need a one-to-one or, very close monitoring, right? And most of your private psychiatric units will have that for the first couple of days, but they don't have that capacity for an ongoing longer term. If there are a private psychiatric unit doesn't have the ability to impose medication on an individual. So there are many, many different things that influence that unit's ability to continue to care for an individual. It's not, does that make sense? Those are just two examples that I could give you.
Any further questions? We're letting her off way too easy.
Well, you know where I am, Mr. Chairman.
Representative Ruiz.
I do have one more. And thank you for talking about this multi-prong, solution, because you're spot on with that. And I'm glad that you also mentioned peer specialists. Having the peer specialists involved is really, really important, especially for those individuals who it's really difficult for them to comprehend and come to an understanding of their mental illness. And then on the back end is what can be also offered in the community side with offering like the resources in the community where people can go and find community with other individuals that may be experiencing similar mental illness symptoms. So we have the clubhouse model, and so they also receive money from, if I'm understanding correctly, from the lottery. There's a certain percentage that goes to them, and they are very critical here. I don't think they get enough attention because of what they are able to do with also helping to help folks avoid hospitalization. Then you only look at the hospital as really as a safety net. It's the last resort, but a person would have been able to try to access other resources before they feel like, I need to go to the hospital because I have no other choice.
Well, and Mr. Chairman, I would just add that you also have the Mental Health America, you have the NAMI groups, you have the consumer-run organizations. We do need those clubhouse programs to be able to be expanded into additional communities. And they're working really hard to do that because those are accredited programs that meet certain measures and provide that kind of local support. The day-to-day lives of people after they've left the hospital, if you will. The other thing I want to say, and I don't think enough attention has been given to this, is that we've invested a lot of money in expanding into the CCBHC model. Those CCBHCs are going to need a lot of support over the next years. This is ambitious. If you look at the list of requirements that a CCBHC must provide to maintain their certification, there's a lot. And so they have to have the workforce. They have to have the training. They have to have those people available to them in order to provide those. So we will be looking at, over the next 10 years, having to provide a lot of support at that level as well. And so that's why you don't want to put all your money into just one can. You have to have the continuum. And we haven't talked at all about substance use. Boy, is that key here. One of the reasons that people who go to the state hospital maybe are not able to be treated effectively sometimes is because they have dual diagnoses. with developmental disabilities or with substance use issues. And so that's why you cannot operate a hospital at the minimum level of funding, because then you don't get at any of that. And then you end up wasting money because you're keeping people forever and ever when they really wouldn't need it if they had the appropriate treatment.
Senator Erickson.
Thank you, Mr. Chair. Thank you so much, Amy. Just a quick question is, you mentioned the CCBHCs and Senator Clifford referred to the community crisis centers. I was just looking at the community crisis centers. First of all, are they the same as the CCBHC?
So they are often operated by a CCBHC. They are a part of what is provided by those centers typically.
And so I just noticed that between 2020 and 2024, community crisis centers were funded $24.5 million from the lottery ticket vending machines.
So if you, so at the beginning of all of this, if you go back to 2018, you didn't have community crisis centers. Okay. And so investing in community crisis centers was a huge part of the strategy in not needing to build another 300 state hospital beds. Because a community crisis center, the police or the family can bring someone to the door of the community crisis center instead of going immediately to the route of involuntary commitment. And at the crisis center, if that person is able to be stabilized and cared for at that level, then they don't have to go on to the state hospital. And so there are great reports about the data of diversion from state hospital admission that we get from the crisis centers across the state. And so in that period of time, we've been expanding the number of crisis centers, the locations, and then now we're moving into the crisis intervention centers where an involuntary patient can be kept for up to 72 hours.
So, which makes perfect sense. So that's like the mobile crisis response.
Well, that's, mobile crisis response might bring someone to a crisis center. A crisis center is an actual place.
Okay, so I guess what I'm getting at, Mr. Chair, is it seems like we've really tried to fund and implement a lot of different pieces to try to address the issues. And what I keep trying to ascertain is the scope of the problem, what current resources we have and models we're using, because it seems very piecemeal to me. You know, we've done the MHIT in schools, we've done the suicide, we've done all of these initiatives, yet we're hearing from what I am gathering is we aren't really scratching the surface on addressing the problem. And so that's what's concerning to me. And I know that the focus of this group is to, okay, we need to, in my opinion, look at the scope of the problem wholesale, what we've currently done, and I think we're allocating a lot of funds and have a lot of programs. How are they working together? How are they not? To solve this problem, because it seems like we are really, every session we have people coming saying, let's fund this, let's do this, and then we hear it's really not making the impact that we're being told it will. And so that's, I guess, what I'm gathering from this 2 days of testimony.
I think we'll deal into that. I think that's one of the problems, or one of the asks, that to find these beds. Some of us in social services budget are familiar. This has been an ongoing thing since 2018 and the mental health report. And the other one that was, what, 2012?
Well, yeah. So if I could, I actually was there's a state hospitals report from 2003 in which the recommendations look very much like the recommendations from 2018. And this is the part I will say. We are making improvements. We are seeing improvements. People are being kept. We are not funneling everyone at the state hospitals like we were 6 years ago. We are, I would say to the people that work within the mental health system, the improvement has been immense. And so if you, and many of you heard my testimony in 2018, and it was desperate and pleading and crisis, and this is terrible. But the aspects of the Mental Health Task Force report, I would really recommend that you look at those reports because they do. They look at the big picture. They look at the system and how these things work together. And I think you will see that those recommendations' intention was to build the continuum of care that braids these things together and moves forward in a way that avoid sending people to the state hospital bed as the first option. It is shocking the percentage of people that show up at a state hospital that have received no mental health treatment or access prior to that. And the purpose of what all of these investments have been is to change those statistics.
Yeah, and if you weren't involved in that, Senator Erickson, this is a plan, believe it or not. I mean, it may seem like when you're hearing this testimony, but this is a plan that has actually been worked out, and I can't imagine how many people would be in our state hospitals and how inundated they would be without these little steps like you're talking about. It may seem, because we're hearing this testimony like this, it may seem like it's willy-nilly, but in the 2018, these steps are laid out, and we've been following them and doing them and contracting in with other hospitals to take these folks and doing preventive measures to keep them from going to the state hospital. There truly is a plan for all that. And I can't imagine how many people without that plan we would be dealing with that went directly to the state hospital. So, but that's part of the information that I'm going to gather because I've been part of it. Some of us in the social service budget have, Representative Bueller, we've been part of this, and the agency has been doing this for quite some time. And it is working, but it's very slow and methodical, bringing the CCBHCs on board. I mean, all those things are, believe it or not, there really is a plan out there. And I'm going to ask the department, the agency, to bring us those plans, bring us a number of these beds. I have read the 2018 report. It basically was a waste of time because it was what the one before that said
Well,
also.
it was 2018 and then 2019.
Yeah.
And what 2019 said was got into the state hospital bed study. How many beds do we have? Where are they? What should we have? And that pointed out to the state that either you start really building out a mental health system or you build several new state hospitals.
Exactly. And so even if it seems convoluted and all that kind of stuff, there really is a plan, and we'll get to the bottom of that in our information in a previous, in the future. So, but there really is a plan, and I think it's working, and we'll hear more about that.
Now we just need the workforce.
Yeah, Representative Bryce.
Thank you, Mr. Chair. Thank you, Amy. Let me ask, I'm a little fuzzy on what is currently available. I think I forget the term you used, but community-based units, like what community outside of the state hospitals. Are there rural hospitals that are doing, for instance, geriatric psych units and operating them? Are they and other entities in the community that are not necessarily the state hospitals? I'm a little fuzzy on what's available out there for inpatient.
So probably what we need to do is to revitalize in the mental health task force report. There is a page that shows the full continuum of care, and that should probably be updated and get some statistics next to it about how many of these do we have, how many of those do we have, where are they located? I think that would be useful for legislators to know. But the issue about inpatient beds that gets really fuzzy is, like you just mentioned, you mentioned geriatric. Okay, well, that's kind of viewed outside of this scope, because there you're dealing with folks primarily with Alzheimer's and, some of dementia and some of those issues. So most of what you've been talking here has been about acute mental health diagnoses like schizophrenia, like bipolar, right? So that kind of diverts there. So you have private hospitals and community hospitals who operate psychiatric units. Some of them have partnerships with the state, some of them do not. You have private psychiatric hospitals like Cottonwood Springs Hospital. That's in Johnson County. You have The children's psychiatric hospitals that are operated by KVC, and I'm forgetting what they like to call themselves now, I'm sorry, Camber. You have psychiatric residential treatment facilities for adolescents. Those are facilities that are partnered with the state and have contracts. And then you have your state mental health hospital inpatient beds. I think I've covered all of the inpatient mental health there. Did I forget anyone? You're whispering? No, okay.
Just a quick question about that. Are there rural hospitals in Kansas that operate geriatric psych units?
Yeah, there were. I don't know how many there are now. Does anybody? Again, that kind of goes into your, there used to be a lot more, I will put it that way. I know that there is one in, it's not Atchison, north of Topeka. But again, that's not Valley Falls. So there are some areas, so geriatric psych units are kind of viewed outside this a little bit. And then you have psychiatric units, which are folks with, that may or may not then move on to a state mental health hospital. Some of them are getting some state funds because they're in the state institution's alternative contracts. Some of them just exist as private psychiatric hospitals. They bill private insurance, they bill Medicaid, they bill what they can.
Right. I know geriatric psych is kind of viewed as outside of what we're talking about, but yet the state hospitals and the staffing for the state hospitals it's included. There are long-term care patients in there, and I was just wondering.
So they do funnel people too, but it would depend on diagnosis. Like you don't admit people to the state hospital because they have dementia. Okay, are there people who are over 65 who have these psychiatric illnesses and they're in the state hospital? If that's what you're talking about, yes, that does happen. There are huge issues that happen there. You may know that Kansas has been under a reform proposal to minimize the amount of mental health medications or antipsychotics that we give to people over 65 because it causes additional issues. So yes and no. I mean, those things merge, but for the most part, we try not to have geriatric patients that just live in the state hospitals, if that's possible.
Right, but they do live there.
There are some,
and they are the Medicare patients. Okay, thank you, ma'am.
And we have mental health nursing facilities also.
So the nursing facilities for mental health are something that Kansas does, and they are not supposed to be a place where someone lives forever. But we do often discharge from the state mental health hospitals to them, but they're not considered an inpatient facility because they're not receiving acute treatment there. Kansas is under a I forget all these terms, prejudicial order because we were sued because we had people that we were putting into nursing facilities for mental health that weren't getting out, that weren't receiving active treatment. And so we have a whole program going on now that the clubhouses and that the community mental health centers are involved in helping people get active treatment so they're able to transition out of NFMHs into the community. And NFMH funding is entire state funds.
Any further questions? Oh, Representative Bueller, sorry.
Thank you, Mr. Chair. And thank you, Amy. So I'm gonna try to go back up to 5 or 20,000 feet, a little higher. For me, when I get into some of these things, we can go down rabbit holes and get in on very important topics, but we sometimes lose track of the why we're here kind of thing. So what I'd like to do is this is my hours worth of noodling, trying to come up with problem solving. But if I start with the big picture problem of contract nursing, state hospitals, and kind of the reason that we decided to come here and go through this mental analysis, in the backdrop, overall health care, quality of care, fully staff our state hospitals and fully serve the folks that are there. So, and understanding that there's different levels of acuity. I'm trying to put this into buckets that we can work on as a group. So, and I'm going back and I'm mindful of the April 2024 subcommittee report, many of which the recommendations that Dayton went through yesterday, we have taken legislative action on. So now get to where we are today. there are 5 things, and what I'd like to know is do you think that is there something I'm missing? Okay, so when I'm looking at this committee, the first one is we can continue as is, which the chairman said we can't do. But even within that bucket, there's things that you mentioned, like the sexual predator treatment option. If this was an option for this committee, what we have to leave here with is a full understanding of the projected cost of the state in the next 3 to 5 years. The legislature needs to understand what that big picture is, and there's things that we can do to nuance that. So if that is one option, continue as is, my challenge to you would come back and say, okay, are there other recommendations if we continue to operate that are very specific that we could get to? That's one thing. So that's one bucket that this group could focus on. Second one is we could partner with a university, and you talked about that a little bit, our university hospital system, knowing that there's some pitfalls, but that is an avenue that we could go down and do some research. Another one is we could privatize, some, part, or all. We could do all services or just maybe some of the ancillary functions. But that's 1, 2, and that's the third bucket. The fourth one I've got is maximize efficiencies of the current system. So, and I would use one example Jenna gave when we talked about restraint and seclusion yesterday. She talked about we talked about, Osawatomie actually brought this up, that there are places where we could look at existing statutes that would make flexibility within our system for the people and positions that are there more efficient, and it would make efficiencies in operations. Medicaid billing might be another sub-bucket in this. The fifth one I have is back to the nursing, improve the nursing profession pipeline. And again, where we started out with the focus on contract nursing, and we heard from the university systems yesterday, and Kylie Childs was here and here's 5 bills that we could do that would help the nursing profession. Those are my 5 buckets. There may be 6 or 7 other ones. Is there another bucket that either that you may have mentioned in that doesn't necessarily get us in a rabbit hole, or is there another place that from your perspective we're missing where we should be focusing our time and attention?
So just backing up a couple, I think you have to look at the Larned campus, what you have there, what you think you have the ability to staff, and how much you're willing to spend on that. I think the whole contract staffing issue is a phase-out plan, not a we suddenly stop spend money on contract staffing issue. Right. One of the things that you don't know is when the Crisis Intervention Center at Hayes is open, how does that impact admissions at Larned? When the South Central Mental Health Hospital opens, how does that affect your admissions at Larned? That's obviously going to divert. Can we open additional crisis intervention centers west of Hayes or maybe in north central Kansas? Are there locations that are ripe for this opportunity that will also reduce admissions into Larned State Hospital? And then you have your plan ultimately to perhaps expand beds at South Central Mental Health Hospital, right? But you have to start that slowly. Otherwise, you're going to wipe out all the workforce in the Wichita area and all the other private psychiatric, all your PRTFs and your kids' hospital, and all of them are going to be running to you and saying you took all of our staff, right? So, and then don't forget the Behavioral Health Center of Excellence plan, the academic partnerships that you have for growing behavioral health workforce. That needs to be on your list for additional report back to you. Where are the successes? Where can we make additional investments in that area? Okay. And then do you have additional hospitals out there that would partner with the state for additional state institutions, alternatives beds? And I think, not to interrupt you, but I think that's a perfect one that we could include in one of these other. We're speaking the same language, is what I'm saying. Right. Yep. And then, look at your areas that are underserved. It isn't just Western Kansas that is underserved. South Central Kansas is also. I think there has been talk about opening an inpatient facility in Southeast Kansas. I don't know how that's going or if that's moving forward, but there are additional opportunities there. And so, I think you guys have the right idea. I think you're moving forward in the correct way. But it took 30 years to put us in this hole. And so the fact that we've been making these investments for the last 6 years, no, we're not there yet. But I believe that we are on the right path. Yep.
Thank you. I appreciate that. Sure.
Representative Bryce.
Thank you, Mr. Chair. Yeah, I appreciate everything, Amy. And I have another bucket, and I've been thinking about this, and my questions about Medicare and about long-term care and about rural hospital involvement. I wasn't sure it was something I should bring up, but my personal experience is I used to be a physician at a geriatric psych unit at a rural hospital, and about 30 years ago. And that geriatric psych unit that moved into that rural hospital saved that rural hospital because they were able to have increased revenue from renting out space, utilizing staff, laboratory services, ancillary services, et cetera. And so in the back of my mind, I'm thinking these rural hospitals that are in need, that's a huge unsolvable problem, it seems. The staffing problems at our state hospital seem to be a huge unsolvable problem. But just in the weird way, I think if we combine those two, we might be able to solve some of them. What I mean is if there are long-term, and I don't know if this is feasible, but if there are long-term care patients, I know some of them are psychotic, schizophrenic, et cetera. It's not just dementia. But if they're in a state hospital and they are relatively low maintenance because they're elderly, is that something that some of these rural hospitals that have a 20-bed wing that they could lease out, that we could decentralize? It's kind of thinking out of the box, but instead of centralizing care for these patients, decentralize over the state, allow some of these rural hospitals that are suffering financially to have another revenue stream, have another potential, then they can recruit staff from their area. It's not just 60 miles around Larned. You try to recruit all these nurses. It's all over the state. And so I guess my question is, thinking outside of the box a little bit, are these patients that are geriatric psych that are Medicare is paying all their expenses basically, or a lot of their expenses.
So Medicare only pays for acute treatment. So just like
Okay.
Medicare will not pay for a nursing home for you or I
Okay.
into our old age, they don't pay for unlimited days in a hospital setting.
So when Larned, for instance, is the testimony was we bill the daily rate to Medicare. That was just for acute care. That was not long-term care for geriatric patients.
That's right.
Okay. Well, that clears it up a little bit for me. Thank you.
But I love that idea.
Committee. Boy, we've got a lot on our plate now. Well, I knew it was going to be a heavy lift, but I know this committee is up to it. Any other questions of Amy? What I will tell you is that Amy has forgot more about this mental health stuff than any of us will ever know. That's just fact.
Forgetting more and more every day.
Very good, Amy. Thank you
Mr.
for
Chairman.
being here. Okay, committee, we are down to available for questions. And I think we've started off with some really good ideas about, obviously, committee, I want to throw this out there right now. And if half of you quit, I get it. But this is probably not going to be something that we solve in this two-day meeting. What I would envision is, and I would be happy to ask the LCC for another day. I know time is valuable, but we do have a meeting on October 1st already scheduled. And I'm thinking that maybe we could do ask for a day, and if they granted it, we could do October 2nd for this committee to meet again and kind of by that time have a lot of questions answered and a lot of material gathered that we need information on. And I'll certainly, what does the committee think about that? Members? I know time commitment. I know we're all busy. You're all busy. I'm not, but you are. But I think that opening up this can of worms, we have really realized that we're not going to come to solutions today. And there's a lot of information that we're going to need to continue on down this road. So with the committee's permission, I will gladly ask LCC for another day. And with Leanne's permission, it would be the 2nd of October. And that way we'd have another 2 day. We wouldn't have to drive up here, drive back. So let's continue on with that mindset. Now with that, I think there's a lot of information that we probably need to get together and ask for today so that they can have it to us by the time we get back. Is that a correct assumption? Mm-hmm. Okay. So with that, we have questions here, but with that, I would probably start down. Leanne, are you kind of ready? I would start down compiling a list of information that we need and want for the next meeting to try to ascertain, run things down, like Representative Bryce was saying, run those things down, what alternatives we do have. I do know that one of the things we have is the state alternative program, but what I've found out in the past from questions is that those are not high security beds, you know, like you would think, like Larned has. And so they take folks, but Scott, you can jump in here if you want to, but I remember thinking we had, when we started entering into those, and we don't have very many, what, 9 or, there's not very many beds around the state.
7 or 9.
Yeah, but what I couldn't understand was these people required security. Well, a lot of the hospitals can't provide that service, you know, so they're not, it's not like you can take someone from Larned that needs, you know, that's violent or those other things and put them in these institutions. But it does take people away there that aren't, you know, violent. So, okay, Leanne, are you ready for information? Committee, go. Representative Reeves first.
I would like for Representative Bueller to talk about your plan, because I think that's a good start.
So I'll go back, and again, so if I was still in the Navy, this would be course of action analysis, kind of the training that you go through when you solve big problems. So again, I started with the whole topic of contract nursing in my head, state hospitals, and I tried to put this in 5 buckets. And so if you'll allow me, the first one was to continue as is. And again, knowing that that's not really what we want to do, but what comes from that to me is, assuming we continue to operate the state hospitals the way they are, we need to understand what the projected cost to the state is, maybe a 1-year, 3-year, and 5-year look. Just seeing the incremental growth in contract nursing, all other things being equal. Within that, we've had several things today, and if there are things that I have forgotten that you might add to this bucket, please feel free to do so. Amy talked about possibly looking at moving or changing or a different option for the sexual predator treatment option. That would be a place where we could add to, we're going to continue to operate as is, but we can still make some refinements. So kind of keep that in the back of your head. The second one that I came up with, and it's not I came up with it, and just listening to what we heard today was, are there opportunities in terms of privatization where we could partner with a university, whether it's KU, and maybe it's just a piece, whether it's the competency hearings or some piece of that. I do think we should take a look at that as a committee to say, okay, is that a way to reduce the overall drain or the burden on our state hospital systems? And I would keep it as maybe finite as that. The third bucket would be privatization. And before I go too deep into this one, there seemed to be an A and a B option. There were all services, assume you're going to do all of everything at the hospitals, maybe just one of the hospitals, but everything at that hospital. An alternative to that would be are there some functions that it makes sense? I don't know that between now and October I would spend a tremendous amount of time on this because I realize it's a big ask, but just to say, are there some things that if we were going to go down the route of privatization, these are the ways we would break it up, and this is what we would look at. The fourth one that I said is maximize the efficiencies of our current system, which is a little bit like number one, I'll admit, but specifically target efficiencies with or within our current staff. Are there ways that we can do that? And again, I use the example of, and this came from Osawatomie, if we changed if we changed the law in terms of restraint and seclusion that allowed APRNs to do it, and Jenna can make this available, I'm assuming, to the committee, what she gave me. This is something that we could do legislatively when we come back in January. So that's one piece of that. Another sub-bucket, and again, this is where I would certainly ask for your help in understanding. We talked about there might be improvements with the way we do Medicaid billing. Representative Bryce talked about, are there partnerships with rural emergency hospitals that we could continue to explore? But again, that would maximize the efficiencies of the current system. And then the fifth one is it's somewhat disconnected or not directly connected per se to contract nursing, but it is that nursing profession pipeline that we spent so much time on yesterday. Again, I think it was Dr. Flanders, that graph that he put out was freaking sobering when we look at the lack of academic preparation of kids coming out of college to get into these professions, declining population, the whole grow your own thing, I think, which is a lot of what was included in the 2024 subcommittee is not possible with those demographic realities. So it gets back to, I would reference the Leading Age Kansas presentation from yesterday. I think there's 5 specific bills in there that really target the nursing profession, and if we took a look at those legislatively in January, that's a good place to start. And I know and I know Representative Reese has mentioned other ones. There's other bills that are out there that could be a potential. Again, that is me putting how do I address this giant problem in different buckets, but those are the 5 that I came up. That's why I asked Amy, is there a 6th? Her comment, if I can find my notes, was don't forget Larned. So as I was listening to her and talking, I don't know if there's a specific Larned analysis that could fit within one of those buckets, or if it's a 6th one. I don't know. And I'm trying to replay back, Amy, what you were telling us not to forget on Larned as a hospital, or we have Lindsay and we have one half of the Ashleys here that could tell us from your hospital perspective what we shouldn't forget about at the state hospital level. So anyhow, thanks for letting me pontificate a little bit.
I think that's great, and a lot of these are going to be redundant. One of the things that we heard from the folks about privatization that I think, given the way we are, is to investigate how we can improve or lessen burdens with technology. And, you know, we've been doing that in the ID and DD where we've monitored people, you know, and you have cameras and you you can monitor their health and stuff like that. I mean, and there may be even more that I'm pretty old, so I don't deal in technology very well, but, you know, I know that there are a lot of technological advances that may dovetail into some of these cost savings or manpower savings, you know, where it's a redundant situation or something like that versus someone has to, and I'm just brainstorming here, but if you check your blood pressure every day and you've got a monitor on, you don't need to do that. So I'm just saying there may be some efficiencies in regarding to technology too. So that could be added to one of your many items.
maximize efficiency of the current system.
Right. So, committee. Senator Rose.
Thank you, Mr. Chair. Two thoughts that I think are in addition to what Representative Bueller just brought up. First, do the state hospitals have the attitude that we want to stabilize our patients and then get them to another facility as quickly as possible? A question I ask is, why are there patients at the state hospitals that are referred to as residents? It should not be their home. Are they being stabilized and then sent to a facility that costs taxpayers less money? And then the second thought I would share is, what efforts are being made between the different levels of mental health care? So you think about the transition goes from community mental health centers, and if their care is not working, then they refer the patient to the state hospital, and hopefully the state hospital stabilizes and gets that patient to a discharge facility as quickly as possible. But my point is, what best practices are being shared between those different levels of care? What can the state hospitals do to share their knowledge and practices with other providers? Because today we're being told, oh, they're the only ones who can do that. Well, do they have a special ability or a special knowledge that they're the only ones in the state that can treat certain patients? And if it's knowledge, can that be shared with other providers to increase the number of providers? But I just look at our state hospitals as the highest level of care and the most expensive, and how can we increase efficiencies by making sure that they're stabilizing, getting the patient to a different facility as quickly as possible, and more providers have the best knowledge available.
Thank you for that. And I think, and I know enough just to be dangerous, but one of the biggest factors is the violence, of a regular hospital just doesn't want to serve someone that is violent, and I think that's what, and these guys can correct me, but I think that's what we house in these other facilities is we're able to deal with those folks like that, whereas regular hospitals that just help mental health folks, can't or don't want to mess with that and risk endangering, hurting nurses and stuff like that. So I think that's what I've delved out of the past is that's the difference is that we're talking about the worst of the worst here. So, but we will get answers to those questions. So committee, Senator Clifford.
Yes, thank you, Mr. Chairman. Senator Erickson pointed out earlier that the State Lottery Fund was contributing $24.5 million to the Crisis Intervention Center approach. I might not put it on Leanne, but maybe in October we could have Kyle back just to see what's going on. Are there centers? What's their success? Is there an appetite for more? I think out west we're waiting on Hayes to open to see what happens. Dodge City has a couple of beds, but it's nominal. So I'd really like to tunnel in on the crisis intervention centers.
Thank you for that. And on my list is, and I looked at some of them, but I haven't done it recently, and Scott can get this for us, is just the number of, kind of a whole chart of how this works, up, down chart, you know what I mean, just a flow charts. Yeah, that's what I was looking for, a flow chart of, and the number of beds that are available in those, and then with that, you have the Breakthrough Club on top of that, which is more the part of, at the end of this, when they leave these facilities, then that's the support that they need to keep from reoffending, so that it's a very complicated deal, but that's part of it is you turn these folks out and they went through treatment, you turn them out on the street with no resources, what do you think is going to happen? They're going to be right back at it because probably a lot of them got there because they've got some serious drug addiction problems and homeless and all that kind of stuff. So you get, if you don't have that support when they leave the mental health facilities, 6 months later, they're right back in there and maybe even worse than before. But that's what I thought, Scott, you've got that. But these beds that we contract with local hospitals and stuff like that. And a lot of these, if you think about it, they do keep folks from Larned. Along with that, how the competency, we've heard a lot about competency restoration and evaluation. So that's 3 words. What does that actually involve? And the timeframes, because they're all different. And so that's, I think, important that we understand how these folks are being evaluated and put into mental buckets, of mental health beds and stuff like that. We have to understand that part of it. So, committee, any other? Representative Rivas.
Yeah, thank you, Chair. I'd like to make a couple comments on, so like this summer, Representative Beeler and I went down to Osawatomie, and Ashley and her team gave us a great tour, and Scott was there. And they were impressive facility. Opened my eyes up a lot. One thing I would say is I think Dr. Bryce was onto this a little bit about rural hospitals and acute care. It's more about, I think, the long-term care, because a lot of their residents there are really nursing home patients now. And so it almost seems like if there was some way to get them into nursing home care, even if it has to be a certain nursing home gets contracted with the state, to move them somewhere like that, because they're a unique population. They may need a facility specific to them, but it would most likely be reimbursable by Medicare and at the same time, or by other means besides state general funds. So there may be a way to get some of that population out. So I'd like to see what that looks like. At least we could reduce some of that. That'd open up other beds potentially for competency or other things. So I think that's another strategy.
Sure. I think that's something we should look at, run it to ground one way or the other. There may be reasons why we can't, or there may, or not. We don't know. Committee, further. Representative Oropesa.
Thank you, Mr. Chair. I just had a few comments. As we look at potential bills and those types of things, I would like to make sure that we include nursing educators as a stakeholder group to really see, to make sure that if we're going to be changing how we educate our nurses, or even kind of adjusting things to hopefully open up the pipeline, which would be the ultimate goal, just to make sure that we're not pigeonholing some of these people who want to advance their degree if they want to go on to more things or become like an APRN or become a CRNA. Not everybody goes straight through knowing what they want to do ultimately. So, and we've had people go from LPN all the way to CRNAs. So, I mean, that is an option. We just want to make sure that as we're looking at this, we're doing it with specific intent, and that we leave those educational opportunities, if the person should decide to do so, advance their degree as they see fit. And I would like to just make sure, as we look at that we include those stakeholders.
Yeah, I think that's a good idea. We heard that testimony yesterday about that you couldn't be some level. It was a regulation more than it was anything, but it's certainly we can put, I don't know how much authority we have to pass laws about that over the regulatory board, the Board of Nursing, but certainly that one deal requiring a master's degree versus a bachelor's and 15 years of experience or something like that is certainly something I believe we should look at. And I think that's pretty low-hanging fruit as far as this whole picture here is making sure, that we're getting a good trainer, but yet, you're relying on their experience. I'll take 15 years of experience over any kind of book learning. I don't care. Give me someone that's been there and done that. I don't care if they've got a master's or not. I'll take that book learning over, or the actual experience over any kind of degree. So I think that's one of our low-hanging fruits on that too. So very good. Representative Reeves.
Representative Bueller has already mentioned this, but if you look at the leading edge document, in the proposed solutions, and I think it's like on the bottom of page 2, there are several bills that are mentioned. And I think being able to combine them all, looking at them, just looking at the bills would be good. And I don't know, I can't see, but SB 2023, I don't think is in there, and that's for the safety of our healthcare staff. And then SB 243 is much more about the competency evaluations. And I just want to put in another plug for this. There is a conference next week in Hayes about our court system and our judiciary system, and when people experiencing mental health crisis are involved in the justice system and what we can do in that. And I know we're going to talk about this bill at that conference. Again, to also look at, to add to the complexity of the individual that might end up in the state hospital. And Representative Carpenter, you mentioned it a little bit. People are homeless. There are a lot of folks that are homeless. We like housing. We like housing supports. There is a way for mental health centers to build supported employment so that people can work and be able to afford housing. So those are kind of type of interventions, I guess, that we can look at. I know Larned needs housing, but that would be a different kind of housing. It would be for staff. But I mean, that is something that's a reality. The large urban cities are experiencing this every day, where folks are going into the psychiatric hospitals, but they have nowhere to go after that. And there are no alternatives. And so it becomes a revolving door. People will come in and out, in and out. So that is something also for us to look at. I would like to hear from Larned staff about the thought of making changes to Larned and the thought of transitioning those 72 acute beds out and having those absorbed somewhere else. What would that look like? I would love to hear from the staff perspective, because they're not here to speak. Obviously, their leadership here is. And thank you for your presentations and speaking for them. But I think it would be great if we could also hear from them. And if we could also hear from folks from the our clubhouses, the variety of our clubhouses, and talk about those of us on the social services budget committee have had the privilege of being able to hear their stories of how important it is for us to build them up too, because then that does become a resource that hospitals have. Even when you're in an acute hospital, at a local hospital, they want to be able to make referrals, not just to a community mental health center, but they want to be able to make referrals to NAMI, to the clubhouses. And so we do need to expand those clubhouses. And if we heard from them about how important it is for them to have that kind of support in the community, so that we understand that there are resources out there, and that we really look at, because then we really are truly looking at our state hospitals as being safety nets, because there are no resources, or the acuity level of that individual has gotten so high that there is no other way to be able to provide treatment. So that would be what I would add for now. Thank you, Mr. Chair.
Very good. Thank you for that. Good deal to end, and maybe have some, we're going to go to lunch here for, what, hour and 15 minutes? Put your thinking caps on, write down whatever you have to do to remember any other information that you think we need before that. And I will say that probably within, Leanne, how much time you need? A week probably to compile this list? in a week's time, but if you see that list and there's something that you want to add to it, don't be bashful about contacting her or me or something like that. You get through and we get through this list and, oh, that's not on there and it's something that you want to know about. Don't be afraid to contact her or myself and we'll get it added to the list so that we can have, we got a month here, a month and a week or two to gather up for the, providing that they give us, and I think they will give us another day. I think leadership is as concerned about this as we are. So with that, we'll break for lunch and see you at 1:15. Sorry about being late, committee. Slow walk back. Where are we at? Oh, we're continuing the information gathering. So, and also fill out your sheets and get them to me. Don't forget. Anybody have any more information or ask? Representative Pezo.
Thank you, Mr. Chair. As we gather information, I would like to look into the service scholarship and seeing how we can tweak that in order to cover non-traditional students, especially those who may only be able to, or maybe raising a family and maybe only be able to do 3 hours a semester, but still wish to enter nursing. Am I allowed to go on?
I'm thinking about it.
Okay, let me.
Yes, you are.
Okay, thank you. I have a list. And then I would also like to request that we look at what program directors are paid at each level of the college aspect, whether it be a technical college, a community college, or a university, as well as what their faculty is paid as the instructors of the nursing students, to see if there's anything that can be looked at or worked on there. And in addition to that, the different levels of nursing that we have in the state that are being taught. So then everybody has a clear picture of kind of what, when we talk about nursing, the different levels that are out there for us to look at. And then one last thing, just for the state hospitals, and as we look at things, making sure they have the flexibility for like an as needed job description. And that's really for people who don't necessarily need the benefits or want the benefits, and maybe their significant other carries the health insurance and various things like that, and would prefer a higher pay compared to actually having any type of, or needing of any type of benefits, retirement or otherwise. Thank you, Mr. Chair.
Is that it?
Yes, that's it. Thank you.
Okay. You have my permission to think of something else, and so if you do. So, committee, further. You already had your chance.
I did? Oh, no, because remember, I punted it over to Rep. Bueller.
Okay, Representative Reeves.
Looking at the Promise Act and other programs like the Promise Act that offers, scholarships, and if you work in the state for 2 years afterwards. And Representative Oropesa already talked about the non-traditional, looking at that aspect. Also looking at to see if these kinds of programs also have a hardship clause to them. I've had a couple of constituents speak to me about going to Johnson County Community College and then having to drop out of that course because they have a parent who has become ill and they're the sole caregiver, so they had to drop out, go take care of their parent. And then 4 months later, when they're ready to go back to school, they really can't. Or they have to start all over again. And I'd heard that if they went through to a different college, and in one particular, they went to Donnelly College. Donnelly College took whatever coursework they had already done and kind of give them credit for that. So, and what I'm being told is that there isn't a hardship clause in the Promise Act specifically. And I would like to see that there too, just because, again, we don't want to turn people away. If we have people that really want to go into the nursing profession, let's bring down some of the roadblocks that might do that. And then a second thing, again, with like these scholarship programs, again, is looking at, I'm trying to think, it just flew out of my head what it was, the other thing I was going to talk about with the Promise Act. Oh, if a person needs to have remedial math or English, can we just build that in? into the Promise Act. So if the person needs that, then fine. Have them take it, and then they'll be ready to move on with their career. Again, it's try to bring down some of these roadblocks, because there's a lot of reasons for people to have problems with math and or English. One of them is trauma. If they've had trauma early on in their life, it will affect that area of their brain. So if they need a little bit more help with that, and they weren't able to get that in whatever school or whatever state they were from, let's give them a chance. Let's give them another chance with that. And then if they're able to do it, then they can move on and hopefully make nursing their career, their life career. Thank you.
You're welcome. Okay, very good. Committee, further items. Let's, I think maybe I've mentioned some of these. I kind of lost track of where I was at. So I had another one to elaborate on the community mental health centers about what services they provide and how they work into this spectrum. And we may have already covered that. I don't remember. But if these are redundant, just scratch them off, you know. And one thing I was curious about was the CMS guidelines. We hear the CMS guidelines. I've never seen those for the hospitals as far as what they'll pay for and what they don't, and the inspection process and how that works. I'd just be curious about that. So maybe, hopefully, somebody else besides me is interested in that. One thing, when Lauren was up here yesterday, and we talked about, and you've had some success at OSH with flexibility, and I understand you have a facility to run, but maybe take a look at some flexibility issues. You know, Renee talked, Senator Erickson talked the other day about, and I had this conversation years ago with the Secretary of Corrections, Ray Roberts was the secretary, about prison staffing. I and Representative Bryce had that question. But this day and age, whether we like it or not, everybody wants an 8-to-5 job and weekends off. And so anything that's a 24-hour facility is hard to staff in those kind of, you know, because you're open 24 hours. So they did that in the corrections facility. You know, they had issues with folks working weekends. And so I think that's part of the problem with the hospitals is that we don't shut them down in the evenings or whatever. They're 24-hour a day, 7 days a week, 365 days a year operations. And that's not how people work this day or how they want to work this day. So, and again, you have a facility run, so I'm not trying to say it, but I'm just saying, just kind of think about it. If you can do some flexibility without jeopardizing, you know, the safety and the operation of the facility, it's just something to think about. Anyway, I had that on my list. I think that's about it. And then, of course, I think that the last gal that was on WebEx could have been interviewing for a consultant's position. But truthfully, I wonder, do we need one? I mean, I'm just brainstorming, do we really need someone that we can hire for a nominal amount of money to dig into this? You know, I don't know. I'm just, your thoughts. And that's basically all I have. Senator Murphy.
Yeah, I was thinking along that line too. I think sometimes we don't know what we don't know. and you get somebody that can come in and look at it, and they may be in a fairly short time for a little bit amount of money comparatively, can really help us, pave the way, so to speak. I've also, I was interested in the connection that they talked about in Kentucky, where the university has taken on some of this. And is there some way we can kind of coordinate that? That would help with the pipeline as well as maybe relieve some stress. So I just,
That's good, very good. One of the things I did want to add to Scott's list is the reimbursement rates for these beds. We pay, I think, for SIA beds, it was what, $900,000 a day or something like that. I can't remember. I said some figure that was incredibly low the last time, and when I had you get those figures, it was quite a bit higher than that. But the cost of these beds that we reimburse through the private entities when you do that. So committee, further. Welcome back. And I hope you realize, I know the committee knows you wear plenty of hats. And so Representative Senator Gossage was wearing another hat today. So she's on, you might tell them what you're on.
I'm on the State Employee Health Benefits Commission. So I serve as a commissioner there to take a look, and we were talking about RFPs and some of the contracts going forward, and there were lots of questions and concerns and looking at prices of everything. And so it was a very important meeting. It just always seems to conflict with, I'm on a lot of interim and joint committees, and Senator Erickson chairs Education Funding Task Force. And Andy Prophet, who is the secretary for the State Employee Health Benefits Plan, is also on the committee. So whenever both of us have to be gone for that, there always seems to be a conflict. So I apologize. I really wanted to be with you. I will go back and, watch everything. I have so many questions, but it's not fair. It's kind of like somebody walking in halfway through a movie and go, "What'd I miss?" I'm like, well, you're just going to have to go back and watch the movie, which I will. But I do think that there are definitely some things, Mr. Chair, just that I come after yesterday's testimonies, and I didn't hear from you, Scott. I'm sure you gave your presentation on some of the questions I have, so maybe I can get that from you privately. But I think that we want to take a hard look at Larned, and should all of those services be provided there? I think that that's a very good point. And I also think, one of the things that my recommendation would be for our next meeting, that we have some of the agencies come in. It's a private company that sees a need, and we're not going to fault them for filling a need. Hey, you guys need nurses? We have nurses. So here's what we have to charge, and this is how much it is. They arrange a payment amount. I'd like to hear from them. How's it working out for them? What of the benefits do they offer compared to benefits that the state may offer, for example? I think that that's something for us to know. And I know we did that a couple of years ago. I was thinking it was in a Bethel meeting perhaps. It's been a while, so I'd like to see that. So I just have a lot more questions, so I'm looking forward to our next meeting to be able to ask those questions. And I know, again, there are a couple of them that I have conflicts that I'm not going to be able to come to, but I will certainly share that with you, Mr. Chair. But I believe we can find an answer. I know it's been hanging out here for a long time. I also don't think it's fair to state hospitals to go like, yeah, guess what? It's too expensive for you to have contract labor, so you can't do that anymore. I mean, well, they have to have nurses. So if we could look at the whole picture. We've talked about the pipeline. There is a pipeline. We do have scholarships that are out there. Why aren't more people wanting to become nurses? I don't have the answer to that. We have a lot of nurses in my family, and who really enjoy it. But you're right, most of them work at hospitals. One's a traveling nurse, the others work in hospitals. So why are they choosing hospitals over the mental health facilities? I think we probably know why, and that's more of a calling than anything else. But I still believe that all of us working together can come up with a solution that is going to be a good solution, not only for the state taxpayers, but also our Kansans that are in these facilities. And, you know, I've read through all the testimonies more than once, and I thank you all for your testimonies, particularly the two ladies sitting right here that are trying to manage these hospitals the best that they know how. And we appreciate you being here and appreciate so much your testimony, and, you know, welcome your suggestions. Now, I am aware it's much easier to say, can we just pay them a lot more? If we could just pay them a lot more, problem solved. We also have to watch the budget, and as I mentioned, we also know the minute you pay them more, hospitals are going to pay more, and everybody else is going to pay more. We're going to be sitting right back here. So maybe there's a solution that doesn't necessarily involve that, but could to some degree. And so that's kind of how I feel at this point, Mr. Chair, if that helps.
Well said. Committee, anything else? Last chance. Senator Rose.
Thank you, Mr. Chair. Another idea, could our universities and their research departments study the treatments at the two hospitals and create data based on what's working, what's not working? Could they study what the community health centers are doing, what's working, what's not working, what changes are made, and also just new innovations to maybe make it quicker to stabilize these patients?
Did you get that, Leanne? Okay. I have something, I can't read my writing here that I haven't scratched off yet, but I think it says diversification, which I think it is, diversification IMD. So I don't even know what that means now.
Sounds good.
But I wrote it down here, and at the time I had the thought, but maybe I'll remember it in the next couple of weeks. Okay, committee. Anything else? I thought you had your,
You said I could think about it.
okay.
Thank you, Mr. Chair.
Representative Opezo.
Thank you, Mr. Chair. As Senator Gossage was speaking, looking at the flexibility with benefit plans, maybe not necessarily pay, but benefits that are offered, maybe more PTO time for the nurses or something that they feel is very, would suit their needs or something along those lines. Just looking at kind of how creative can we be with the benefit options, and looking at that further. So thank you.
And when she was speaking, that made me think of something else as well, which is surveying the nurses. And I know that, I believe that you brought the survey from Osawatomie to us, and both of you did, and we appreciate that. But maybe surveying those, both sides. Why do you work for the state when instead of, you know, what is it about working for the state that you like better than working with contract nursing? If you're working for contract nursing, what do you like about that? Why do you choose to do that as opposed to, you know, working for the state? And perhaps not necessarily open-ended. Some people aren't good with, you know, writing a dissertation. They would rather you ask questions, but then always offer an opportunity at the bottom. And I think it's important, too, that they not put their name on that. Right? If they're anonymous, they're going to really tell you what they think. If they feel like, ooh, they're going to go back to a contract agency and tell them this or, you know, whatever. So any additional information like that, I think, is extremely helpful for us to know what is important to them. Is it benefits, like we talked about? For some, as you mentioned, that it's salary. No, I work with employee benefits all over the country, and you often will have people like, whatever, I never really use the insurance. I wish they'd just do X, but so we have to look at that whole picture. Thank you. That's a very good point.
Last chance. Okay. Well, with that, I want to thank everybody. I want to thank you for your time, your commitment to this committee, and your continued commitment to this issue. And I want to thank staff for everything you've done. And of course, I definitely want to thank you guys that run the hospitals, boots on the ground folks, for what you're doing. And I hope that none of this transcribes into any animosity or any kind of a deal like that. We're just trying to help. So we're not, we're just trying to help our hospitals. So conferees, thank everybody. If there are folks that were on WebEx that were here and anybody that testified and spent their time or let us use their time, we appreciate that. And with that, we're adjourned.